I think we'll start. Huh? We'll start. Okay. Good morning, everybody. So, welcome to this CME and hands-on workshop on models for surgical pulse in craniosynostosis. So in this program, you will basically learn to begin with general overview of craniosynostosis, evaluation and management, genetic evaluation of craniosynostosis, and instruments used for surgery for craniosynostosis, and various surgical procedures like anterior procedure, posterior procedure, whole cranial procedures, minimal invasive procedure like endoscopy with helmet therapy. Then after lunch, we'll go to neurosurgery skills lab, and you can practice on the models. So basically, we'll demonstrate where to make cuts for each type of surgical procedure. And then few of you will get opportunity to do it yourself, depending on the number of participants and number of models available in afternoon. So first, I'll start with myself. I am Dr. Dhaval Shukla. I am Professor of Neurosurgery, and currently I'm heading the Department of Neurosurgery. So I'll be giving you a brief overview of craniosynostosis, and details of each surgical procedure and evaluation procedure will be covered by the subsequent speakers. So what is craniosynostosis is basically synostosis. Not able to hear? Hello, am I audible? Huh? Huh. So synostosis means fusion of bones is called synostosis. So when it happens in the cranial bones, it is called craniosynostosis. So there are four major sutures of the cranial vault, with both coronal sutures, Lambert suture, both Lambert suture and sagittal suture. And one more suture which we do not see in day-to-day neurosurgical practices, metopic suture, because it fuses too early. So by the time each one of us start doing craniotomy, we would not have seen metopic suture, but that is present at birth. So these sutures are present to allow brain to grow. So they are not fused so that brain can grow. All of us have a particular head shape. That is because of our brain, not because of our skull. It is the brain which decides the shape of any living creature, whether it's a dog, monkey, or humans. Like monkeys, you see that his forehead is flat or recessed because their frontal lobes are not developed. Our frontal lobes are developed, so we have frontal palsy. So this is how brain decides the growth and shape and size of the skull. So what happens, this metopic suture usually fuses by 3 months of age to up to 2 years of age. Sometimes it can take. However, it may persist in up to 10% of children. And sagittal suture fuses by 22 years of age. Coronal suture fuses by 24 years of age, and Lambert suture fuses by 26 years of age. So any fusion before to that will be considered premature fusion, but it will not make any difference because brain stops growing beyond 6 to 7 years of age. So if any of the sutures fuse after 7 years of age, it will not make any difference. But if the sutures fuse before that, it can make difference. So the common patterns of synostosis are like sagittal synostosis, where the sagittal suture is fused. So principle is, if a suture is fused, the skull cannot grow perpendicular to the suture. So there will not be growth on the biparietal region if sagittal suture is fused. So there will be growth parallel along the long axis of the suture. So there will be growth in the frontal as well as in the occipital side. So head becomes long. In metopic suture, again, there is no growth in the either side of the suture, so it becomes triangle in shape. In bilateral coronal synostosis, it cannot grow front and back, so it goes on top. In unilateral, same thing, it cannot grow front and back on the side of few sutures, so it compensatory growth occurs on the opposite side. And Lambert suture, same thing, compensatory growth occurs in opposite side. And there is something called deformational posterior plagiocephaly, or also called as positional plagiocephaly, which occurs due to sleeping position that I will tell you about later. So common is sagittal synostosis, followed by unilateral coronal, followed by metopic. Lambdoid is very rare. Like in your pediatrics posting during your MBBS, you must have learned that how to differentiate Lambdoid synostosis from positional plagiocephaly. But it is very rare. So you need not to bother too much. So what causes non-syndromic craniosynostosis? We don't know. Nobody knows actually. And most often it is sporadic. Some genetic mutations are known, more than 100 mutations are known to cause craniosynostosis, like FGFR is commonest, then twist, and so on, that you will learn in the next lecture. Some metabolic and hematologic syndrome like vitamin D excess or vitamin A excess can also cause hyperphosphatemia, may cause sickle cell disease, may cause valproic acid and retinoic acid exposure during pregnancy can cause craniosynostosis, and maternal smoking is associated with craniosynostosis, and advanced paternal age is also associated with higher incidence of craniosynostosis. Our syndromic craniosynostosis comprise less than 5% of all the craniosynostosis, and that will be dealt later in the next lecture on genetics. So this graph you must have seen in Cadbury Bonvita's Little Champs advertisement, that 80% of the brain grows in the first 2 years of the life. Then after that, brain growth is slow. So why this is important to know? So if you have to intervene, you have to intervene early in the first 2 years of life, so you can allow brain to grow. After that, the growth becomes slow. The maximum growth is in first year of life. So it is better to operate upon a child when he or she is still an infant. Then within 6 months it doubles. So it is even advisable to do surgery within first 6 months rather than to wait even up to 1 year. But after 6 to 7 years, brain does not grow further, and sutures will also not allow skull to grow. And whatever shape you get at the end of 6 or 7 years, whether the child has or does not have craniosynostosis, that shape remains more or less final for the entire life. So what is positional plagiocephaly? Like it is can be akin to one balloon filled with water. Like when you fill a balloon with water and place on the hard table, the bottom portion of the balloon becomes flat, the rest of the portion becomes convex. And microcephaly, you don't inflate the balloon enough, so the balloon appears smaller in size. The same thing happens to the skull also. In positional plagiocephaly, the flat portion, the portion on which the child sleeps, remains flat and rest bulges. And in microcephaly, because brain does not develop, the size of the brain is small, the skull also does not grow. So there was an epidemic of positional plagiocephaly in 70s, 80s because of recommendation by American Academy of Pediatrics. So during 70s, 80s, there was an epidemic of sudden infant death syndrome, SIDS. So that used to happen. That was also called as crib death, because when the child is lying in the cradle, and if the child is lying prone or one side, he may smother himself or herself, and the child dies. So AAP recommended that all the child should be made to lie flat while in sleeping position. So because of this sleeping position, the children used to get positional plagiocephaly. So that was called back to sleep campaign. Others, Pawan, can you mute? Others can mute yourself, please. So this is akin to, this is watermelon, which was made in Japan. So when the watermelon was growing, they put it in iron tube. So when the watermelon became full grown, it was cubical in shape rather than spherical in shape. The same thing happens in positional plagiocephaly. You make the child lie flat, the posterior portion becomes flat. So how to differentiate positional from the craniosynostosis? You have to ask, is the deformity present at the birth? Because most of the time the premature fission will occur in utero. So you will see the deformity as soon as the child is born. Whereas in positional, over time the deformity develops. Is there a preferred sleep position? Like you can ask mother how the baby sleeps. So if you remember in our traditional Indian family, there is in Tamil Nadu, they call tutti. Yeah, with sari or with towel or something, you make a makeshift cradle. So it will have a convex surface. So that will give a good round shape of the back of the head. But in the modern cradles are flat with remote control, auto swing, and all the things. Mothers do not stay also with the baby. So such type of babies, if they have such type of cradles, they may have positional plagiocephaly. What happens as the once the child grows, the child spends less and less time sleeping. Most of the child by 6 months of age, they don't sleep too long, like 20 hours or 18 hours. They sleep hardly for 10, 11 hours. So most of the time they are awake, they are up and about, they are sitting or standing or walking. So brain starts growing and the deformity corrects on its own. So this is how you differentiate positional versus synostosis. So you look from the back of the head. In the synostosis, the mastoid is pulled down, ear is also pulled down, whereas in positional, the position of the ear remains parallel. When you see from the top, it is parallelogram in shape in positional, whereas it is trapezoid shape in case of lambdoid synostosis. So this is example of microcephaly. So here you can see that when you see grossly, there is some stepping here. So you feel this is a case of craniosynostosis. And I get a lot of referral like this from our child psychiatric clinic. The baby's head base is small, and when you feel the head, there is some step. So for residents, how to differentiate clinically whether it is microcephaly or is it craniosynostosis? So microcephaly head circumference definitely will be less than 2 standard deviation. In craniosynostosis, because there is a compensatory growth of the rest of the skull, so head circumference will not change. In pancraniosynostosis, yes, the head can be small. And second differentiating point in microcephaly, you will feel the step. So when you palpate, there will be step. Whereas in case of craniosynostosis, there is a ridge. So you have to differentiate between ridge and the step. If it is step, it is microcephaly, and if it is ridge, it is craniosynostosis. So this, you can see the CT scan of the head. There is we don't have MRI, but there was migrational defect. That's why the brain did not grow. Brain volume was less, and the child looks small. So in this microcephaly, the head looks small. The rest of the face looks fine. So again in 1920s, so there was again epidemic of surgery for craniosynostosis. So all the microcephalic babies underwent surgery for craniosynostosis, believing that if you increase the size of the skull, the brain volume will increase and the babies will have normal IQ. So the mortality of that procedure during those times was 80%. So people realize it is not the skull, but it is the brain which decides the IQ. So increasing the volume of the skull did not improve the IQ. So there is no role of surgery for microcephaly. So I come to individual common type of craniosynostosis. So this is one more point to be differentiated, metopic ridge. So as I told you, the metopic fusion occurs early, within 2 months or something. Suppose it occurs late. So an astute clinician will, at the time of head circumference monitoring, will be able to feel some ridge in the forehead, in the middle of the forehead. And he may feel it is craniosynostosis. So it is just a ridge, not a craniosynostosis. So how do you differentiate? So there will be ridge. There is no retrusion of the orbit. So the orbit looks fine. The intercanthal distance is normal. So there is no hypotelorism. So this is not a craniosynostosis, and such children do not require surgery. Earlier, people have done a lot of surgeries for metopic ridges, but they do not require surgery. Only thing is when the child grows up and child is too much concerned about feeling the ridge on the middle of the forehead, or mother is too much concerned, you can do endoscopic procedure and just flatten the ridge rather than remove the entire suture or remodel the front portion of the skull. So this is metopic stenosis. So when viewed from above, metopic stenosis, it appears triangle in shape. The forehead appears triangle in shape. There is a retrusion of the orbit. And when you see from front, you see prominence in the midline and intercanthal distance is narrow. So this is called hypotelorism. So this is metopic synostosis. So I have shown in all the subsequent slide, the upper panel, normal skull, and lower panel, the pathological skull. So you can compare with that. So as compared to normal in the metopic synostosis, you can see hypotelorism, midline ridge, and from the side also there is a flattening of the forehead on both sides, and from top it is triangle in shape. In sagittal synostosis, as I told you, there is compensatory growth occurs in front and back. So forehead appears more prominent, and side viewed from side, the head appears long from front to back. So this is sagittal synostosis. So comparing from top, there is prominence of the forehead. There is dolichocephaly, and viewed from the top, again, there is a dolichocephaly. And in some cases of sagittal synostosis, there can be too much compensatory growth of the forehead and of the occipital region. So it appears boat shape, like boat has got front and back, hull, and can someone mute? The person who has joined can mute, please. So in boat, like front and back, hull and mask of the back boat are like prominent, whether the center portion of the boat is flat. So it appears boat shape. So it all depends when the synostosis occurs, at what stage of development occurs, whether the anterior portion of sagittal synostosis occurs early or the posterior. Depending on that, there may be occipital bullet or there may be frontal bossing. So this is a case of unicoronal synostosis. So this were the twin babies. So it appears the baby who is crying actually is normal. The one baby who is not crying is normal. So as if in uterus, this another baby would have punched on the face of the other child. You can see there is flattening, or actually the forehead has gone inside on the right side. The right side orbit, there is a retrusion, and there is a compensatory bulge on the left side of the forehead. And the root of the nose, you can see, you feel that the nose, tip of the nose is deviated to left. Actually, tip of the nose is not deviated. It is the root of the nose, which is deviated towards the synostotic side. So looking from the close-up and with the CT scan correlate, you can see this is called Harlequin orbit deformity, where the height of the orbit is more, whereas and side-to-side diameter of the orbit is less, and there is a retrusion. So one more additional point is if there is this is only coronal suture. You can see there is no coronal suture on the right side, but coronal suture is present on the left side. In addition, if there is a frontosphenoid suture synostosis, there will be bad orbit deformity, and there will be a lot of retrusion of the orbit. So that will require additional correction of the zygomatic portion as well. So this is from the normal side. Again, you can see frontal bulge. On the abnormal side, front orbital retrusion and flattening of the frontal bone. And viewed from the top, like there is a retrusion of the orbit and the flattening of the frontal bone on the right side. In bicoronal synostosis, head does not grow front and back, so it will go up vertical. That is also called turicephaly, means tower-like skull. So you can see the baby's skull is top, and viewed from side, it definitely looks like tower-shaped skull. So this is comparing with the normal panel above. You cannot see coronal sutures on both sides. The skull is flat from front to back, and the height of the skull is more. So these were the common single suture synostosis, whereas multiple suture synostosis can occur. So multiple suture synostosis can occur, usually in syndromic cases. So there can be various patterns of synostosis. For example, this is a common pattern called Mercedes-Benz pattern on the top side. So sagittal suture is fused and both lambdoid sutures are fused. So it gives like Mercedes-Benz pattern sign. So another uncommon is like bilateral coronal sutures are fused and sagittal. So it gives like our Tata Motors sign. And there can be various combinations like metopic plus coronal. So these are seen usually in syndrome like Apert-Cruzen, Seider-Schwarzen syndrome, or Springson-Goldberg syndrome. So this syndromic children with multiple suture synostosis, they have a lot of problems, and that will be dealt in next lecture. It's not correct. So one more condition is pancraniosynostosis, when all sutures are fused. So what happens? One possibility is they fuse later in life, all sutures. So brain still grows up to some extent, but not fully. So the shape of the head looks largely normal. So this is called as normocephalic craniosynostosis, normal looking head, but all sutures are fused. So these children usually present later in age, some 6-7 years, but typically when they start going to school and when they are not able to see the blackboard, what teacher is writing, at that time, vision examination will reveal that they are developing blindness. That is because of raised intracranial pressure, because intracranial volume is less. So when you see the skulls of such children, these are called smooth skulls. There are no sutures. Can you see there are no sutures? It's a smooth skull. So it is important to recognize this condition. So head may look normal, but on the face, if you see the eyes are popping out, that is because of raised pressure. You can see more prominent forehead and facial veins, which will indicate venous hypertension. So when the premature fusion occurs early, so what happens? The brain cannot grow at the site of fused suture. So wherever brain is getting space, brain starts growing in that region. So this gives rise to bad deformity called clover leaf skull. This is also pancraniosynostosis, but this occurred early. So the shape of the skull is not normal. And wherever brain gets space, brain starts growing. So this gives rise to a bad deformity called clover leaf skull. Evaluating a child with craniosynostosis with imaging, like we all want to avoid X-ray, CT scans, etc., because of radiation hazard. So ultrasound can be used for evaluation of craniosynostosis. Many centers for single suture non-syndromic synostosis, they do not ask for any CT scan. You can do clinically also, you can evaluate in ultrasound. So 11 megahertz linear transducer, which has kept perpendicular to the length of the suture and how you differentiate whether it is fused or not. So you will see an hypoechoic or anechoic gap, which indicates the suture is open. If you do not see, then suture is closed. So this is an example, like in case of this, like metopic sutures, you cannot see the gap. But here you see in this case of unicoronal, on the affected side, there is no gap. But on the unaffected side, there is a gap. Can you make out the gap on the figure 2C? So similarly, in this case of sagittal stenosis, the front portion is fused, but the back portion is not fused. And other thing you can say is ridge. There is, as I told you earlier, step and ridge. So you can see the ridge, which indicates it is craniosynostosis. So ultrasound can be used to diagnose craniosynostosis. Then there is one more MRI sequence called fracture sense sequence, which is available in Siemens, but the name may vary in the different MRI manufacturers. So this is also called black bone MRI. So this top panel is MRI image and bottom panel is CT scan. We have acquired this sequence recently, but we are not yet using as a replacement for CT scan. We are using along with CT scan just to validate whether MRI looks as good as CT scan. So upper panel is MRI and lower panel is CT scan. So you can, it correlates more or less, the appearance is more or less similar to the CT scan, though not as accurate and as fine, as high resolution as the CT scan. But yes, with the improvement in technology, we will be able to replace CT scan for craniosynostosis. So this, besides doing the bone, you have to look for brain also, which I'll come in later slides. So additional findings you have to look for is hydrocephalus, presence of emissary veins. So in this case, you can see there is a prominent supratrochlear vein. So because of craniosynostosis, there may be stenosis of jugular foramen. There may be non-development of sigmoid sinus or jugular vein. So sometimes such big emissary vein may be the only venous drainage for the brain. So when you are doing surgery, you have to study venogram carefully. And if you sacrifice that vein, patient will have postoperative intracranial venous hypertension. Additional finding, you have to look for the findings of raised ICP, like here you see empty cella, there is a CSF leak in the sphenoid sinus, there's tonsillar herniation, there is syringomyelia, and in this case, there is corpus callosal agenesis. So don't think craniosynostosis only is a carpentry and only a skull surgery. It is associated with the brain anomalies as well. So venogram, like there is a sharp cutoff at the transverse sigmoid junction. And because of that, what happens, the collateral veins in the suboccipital venous plexus become very prominent. So if you're going to do surgery for Chiari malformation in this case, there will be huge venous plexus. And moment you cut the skin, there will be enormous bleeding. So to study venogram freehand before you cut. Hydrocephalus occurs more often in syndromic rather than non-syndromic. And asymptomatic ventriculomegaly is common in APAT, but symptomatic hydrocephalus is more common in Pfeiffer syndrome, and it is described in many other syndromes as well. So this is an example of syndromic craniosynostosis. At 18 days of age, there was no hydrocephalus. There was a clover leaf deformity. And the parents ignored, there is nothing, the shape is abnormal. They were happy with the shape. But what happens at 18 months of age? There was a massive hydrocephalus. There was fusion of sutures, and only suture which was present was sagittal and metopic. So brain was like literally herniating out of the herniating out in the midline. So this was very gross, bad deformity. You can see in the posteriorly also, wherever space is available, brain is trying to herniate out. So other causes of raised ICP, I already told, venous stenosis, and other signs of raised ICP should see like perioptic nerve, CSF spaces are more. And this syndromic children, they have upper airway obstruction, which will lead to carbon dioxide buildup. That will also cause raised ICP. They have obstructive sleep apnea, which will also cause carbon dioxide buildup and raised ICP. Chiari 1 malformation can cause hypoventilation, which can also cause raised intracranial pressure beside hydrocephalus and venous hypertension. So this is one case, again, venous hypertension. You can see very prominent vein. So you have to tailor your craniotomy so that you don't disconnect this vein from the sinus. Intracranial pressure monitoring can be done pre-op, intra-op, or even post-operative. So we do intraoperative intracranial pressure monitoring. So particularly for bicoronal synostosis, when you try to correct the height, there can be sometimes pressure on the brain. So you see this pressure was 9, which increased to 15. So you can tailor the amount of cranial remodeling required depending on intracranial pressure values. So child, whether syndromic or non-syndromic, requires comprehensive evaluation, because what happens at the presentation, there may be single suture involvement. But as the child grows, multiple sutures can get fused. And if you miss the opportunity of evaluation at the first instance, the child will come with mental retardation and blindness later. So all children are referred for airway evaluation, intracerebral abnormalities, already told, cardiac abnormalities, particularly in Springs and Goldberg syndrome, it is common. In Apert syndrome, patent ductus arteriosus can occur, which is usually harmless, but still you need evaluation. Papilledema is a proxy for elevated ICP, but that is not a substitute for ICP monitoring. And corneal exposure, this syndromic children have proptosis. So tarsography may be required before you do cranial surgery. They may have secondary cleft palate. Hearing loss is known as Menkes syndrome. Malrotation of gut can occur in Crouzon syndrome. So you may be wondering, while the child is cranky, surgery has gone well. That is maybe due to intestinal obstruction and malrotation of the gut. Then intellectual disabilities are more common in Pfeiffer syndrome and congenital limb anomalies in Apert syndrome, which will be dealt later. So in our hospital, these are the 9 forms, 9 referrals a child with craniosynostosis receives. So he visits 9 different places like craniofacial, ophthalmic, speech pathology, cardiology, general pediatric surgeon to look for any other abnormalities, genetics, etc. So first question, when a small baby comes, the parents ask whether surgery is required. Nobody wants their small child to undergo surgery. So why surgery is required? Obviously for correction of skull shape and aesthetic reasons and psychosocial reasons, surgery is required. Why psychosocial and aesthetic are important? By the time of 2 years of age of child starts looking himself or herself in mirror. The child has developed narcissism and self-love, self-appreciation. So when the child looks in the mirror, child realizes that I look different from other children. So that this child will not go to play school, this child will not go to normal school because the child feels that I look different. So you have to do surgery early before the child develops self-image. So this was a classical example of negligence. Mother had Crouzon syndrome. Both children look like mother. So nobody will feel that children look like mother, it's normal. So none of the 3 bothered about craniosynostosis. Luckily, mother did not have any problem. She grew up well, adult. But both children, they started developing blindness. At that time, somebody suggested that there is papillida, there is something wrong with your brain. And then craniosynostosis was discovered at 9 and 11 years respectively. So it's not only for appearance, it is also for some other reasons. So some other reasons are basically for allowing the normal brain growth. So if the craniosynostosis, brain growth will not be normal, vision will be affected due to raised ICP. However, the relationship between the craniosynostosis and brain development is not completely understood, but perfusion studies have found that there is hypoperfusion. At least regional hypoperfusion is definitely there in children with craniosynostosis. And this improvement in perfusion may help brain development later. Now, again, second question the parents will ask. First question, they already asked surgery is required or not. Second question is asked, when can we do surgery or can we defer surgery due to some social reasons? The child has got first birthday next month. Can we defer to next year or something like that? Can we defer after DPT vaccination? Those are the common practical questions parents ask. So yes, it will look worse with time. Particularly sagittal synostosis looks definitely worse with time. If you leave, the child looks more and more ugly. So it is better that you operate by 6 months of age if you have facility available at your hospital. So timing of surgery, simple strip craniectomy using endoscopic with post-operative molding helmet is good if the child present by 3 months of age. By 6 to 8 months, posterior cranial vault distraction is preferred rather than fixed expansion. Then by 10 to 18 months, like whole cranial vault correction or frontoorbital advancement. By 5 to 9 years, midface correction. 9 to 12 years, again, monoblock advancement can be done. And by 15 to 20 years of age, you may require additional facial surgery because once the children go to college, they have different perceptions of themselves. They want minor corrections in their appearance. So you have to counsel a child with craniosynostosis. By the child may require multiple surgery till the child starts going to college because some minor corrections may be required even later. So surgical outcome of appearance, like there are 2 scales, Whittaker scale and Sloan. Whittaker is done by surgeon and Sloan is by parents. So this is difficult to comprehend. So I have made a illustration to understand this scale. So basically, the purpose is correction of the shape. So whether the correction is good or correction is bad. If the correction is good, are there any irregularities? If there are no irregularities, we call it class 1 outcome. If there are irregularities, whether these irregularities require reoperation, they are so bad that requires reoperation, class 4. But they are not bad, they do not require reoperation. Whether the irregularities are only felt, like when you palpate the skull while giving bath to baby, then it is class 2 outcome. But if they are visible irregularities, we call it class 3 outcome. And if the correction is bad, requiring reoperation, it is class 5 and class 6 outcome. So these are the example of class 1 outcome of metopic synostosis. You can see top panel pre-op and bottom panel at follow-up. So absolute correction, no complaints from the parents. This is the class 2 outcome in which you can see some gaps, right? Here. So while giving bath, the parents were concerned. They are able to fill the gaps. So they did not rate. I asked parents themselves to rate the outcome. So they themselves rated it class 2 because they were not happy filling the gaps. Where in this class 3 outcome, there was visible vertex. Can you see one vertex prominence is there? So it is visible. That is class 3 outcome. Class 4 outcome is correction is good, but there is a protrusion of one of the implants, which requires surgery. So it will be considered class 4 outcome because it requires surgery, right? Then class 5 outcome, it is like what you saw in your Sunday newspaper, spot 6 differences between top and bottom pictures. Here you can see from top and bottom, it looks more or less same. So the parents were quite grossly unhappy with the appearance. This is at the time of first follow-up. It looks more or less same like pre-op, but they refused to undergo surgery. But as the child grew further, there was some symmetry was naturally obtained because the brain started growing. So the asymmetry which was there at first follow became less prominent at later follow. So not all unacceptable outcome require resurgery. You can wait for some time. So concluding, like parents have different expectation and perception of outcome of surgery. So we have to involve parents at all the stage of decision making and surgery. And most important is parent satisfaction, like IQ, your sphenopetrosal angle, cephalic indices, and all. They don't matter any. They are good for your publication and showing p values, but they don't matter to parents. So parents should be satisfied in terms of appearance. Parents should be satisfied in terms of performance of child in school. So that is more important. And one should refer to center of excellence with high volume and multidisciplinary centers if you want the outcome to be optimized. So we have parents advocacy, like we conducted the awareness program last year. See, this all are children with craniosynostosis. Some of them are siblings in the group photograph. Some are the patients themselves. And this is like most satisfactory outcome. So this is a birthday party, small birthday party. And one of this child underwent craniosynostosis surgery, and you cannot make out which is the abnormal side. So that is the ultimate goal. The child should be integrated with the peers without other children letting know that this child underwent a surgery on head during infancy. Thank you very much. So we'll invite for the next lecture. So we are not having question and answers because we are having hands-on session. So you will have more opportunity to interact directly with the speakers if you have any doubts or questions, rather than just giving 1 minute for question and answer. So I will invite next person. Our next speaker is Dr. Gautam. So Dr. Gautam is basically a psychiatrist in our hospital, is an additional professor. And after doing psychiatry, he did fellowship and further specialization in clinical genetics. So currently, he is the only person who deals with clinical genetics. We have one genetics department that takes care of basic science research and all those aspects. But Dr. Gautam runs clinical genetics clinic on Wednesday, thrice a week, 4 days a week, and all not only craniosynostosis, all neurological disorder children and adults also, they are referred to Dr. Gautam. So what I called a person like Dr. Gautam, like our children who were earlier known as baby of Uma Devi, after visiting Dr. Gautam, they are known as Cruzen syndrome. So they go for naming ceremony to Gautam. So I asked Gautam to give a talk on genetic evaluation for craniosynostosis.
Thank you very much, sir. Good morning, everyone. So, what I'll deal with, I don't want to bore you with deep genomics and genetic knowledge, but I thought I'll give you a brief introduction how to evaluate because it's the genomic era. So, craniosynostosis is a frequent concern for genetic evaluation in our OPD. Even though individually they are very rare, but put together they form a substantial proportion of cases, even breaching the rare disease definition. So if you see the prevalence, it's about 1 in 1,500 to 2,500 births from various reports. Now, etiologically, craniosynostosis is quite heterogeneous. Even chromosomal disorders can cause craniosynostosis, monogenic disorders, multifactorial, and sometimes completely environmental teratogenic factors. Now, we divide craniosynostosis into two types, syndromic and non-syndromic, based on the Tonne et al., based on the following criteria. If one of the criteria is fulfilled, we call it as a syndromic craniosynostosis. If there is a major dysmorphic features are there, significant developmental delay, severe autism, or multiple congenital malformations, or two or more of the same four in milder form with epilepsy and impaired hearing and vision. So even though non-syndromic craniosynostosis is, the proportion of cases are very high, they hardly come to clinical attention many a times. So whatever cases that are seen in a craniosynostosis clinic or in a genetic clinic, usually the cases are 1/3 of syndromic and 2/3 are non-syndromic cases. So first and foremost, the question comes as why a genetic diagnosis is required. Because after all, the child has come for surgical evaluation and surgery. Why a genetic evaluation or a diagnosis? So we geneticists give various syndromic names, fancy names like Ballard-Gerald syndrome, Sprinzen-Goldberg syndrome, Barrett-Winter syndrome. Are they just fancy names or do they have more meaning to it? So as soon as you give a proper genetic diagnosis, there will be validation of the symptoms. The symptoms become credible. Many a times, mother may be thinking that I ate this during pregnancy, I fell during pregnancy, or the baby fell from the cot, and that is the reason for the skull deformity. But when you give a diagnosis, that anxiety is allayed, the blame game between the family members is allayed. So there comes the importance of genetic diagnosis. It will also provide accurate prognosis. For example, if it is Pfeiffer type 2 or Apert syndrome, even after surgery, the developmental problems may persist. And accurately to manage which cases to be operated, which cases not, and where to procure such treatment services. Of course, many of these neurosurgical procedures are not available in the district headquarters. Most importantly, prenatal diagnosis, that they want to avoid such a recurrence in the next pregnancy. And as Sir showed, to allow the parents to join support groups. I'll just show you with few examples. These two patients presented with craniofacial dysmorphic features. You can see that there is prominent forehead with frontal bossing, prominent eyes, almost like proptotic, and hypoplastic malar region and micrognathia brachydactyly. And this child also had similar features and hypodontia, very few teeth. Any guesses? Any diagnosis? Okay, so that is more crowded teeth. So what you can see here is much more osteosclerotic skulls. Okay, here the craniosynostosis is not there and hypodontia is there. As you can see, it is osteopetrotic. So whenever you see such a case, you know the diagnosis. And the most important diagnosis which clinches the diagnosis is the loss of angle of the mandible here. It's almost obtuse here, right? So the diagnosis is pycnodysaustosis. Many children with pycnodysaustosis can have craniosynostosis as well. Both were genetically proven. So why do we need this diagnosis? Because the treatment of pycnodysaustosis is like this. So if children have craniosynostosis, they require neurosurgical procedures. And they may have cleft lip, cleft palate, which requires again surgery. Most of them will have short stature and require growth hormone as they grow up. And many of these, because of the osteosclerosis, will be prone for fractures. So you require proper therapy for management of fractures. You cannot give bisphosphonates because already the bones are osteosclerotic, so it is not the problem with calcium deposition. So then they will obviously have, because of maxillary hypoplasia, they will have ventilatory issues, that is sleep apnea, snoring, and so on. So that may require attention. And many of them have optic nerve compression, which requires decompression. So a diagnosis provides you actual guideline how to treat and where to treat such problems. Just to refresh your first year biochemistry knowledge, the gene is in two compartments, the nucleus and the mitochondria. We have 46 DNA molecules, which are extremely long, hence they have to be wound around the histone protein, histone which undergoes several conformational changes to pack the entire DNA molecule into a small chromatin. And each of the chromosomes, each of the 46 chromosomes occupy a particular three-dimensional space in the tiny nucleus. So the entire genome consists of about 3.2 billion bases, 3.2 billion from mother, 3.2 billion from a father. And if you look at all the nucleotides, just 1% is coding. So as clinicians, we are only interested in the protein coding genes, which is about 20,000. So how do we identify such small 1% of the genes in the genome? All the protein coding genes have a particular structure. Wherever you see a nucleotide sequence which tells you this is regulator, promoter, UTR, first codon, exon, intron, and the similar things, stop codon and 3' UTR, you know that there is a protein coding gene. So how do we classify genetic disorders? We have only three subtypes. One is chromosomal disorder. For example, you have deletion 9p, which causes trigonocephaly syndrome, and 22q11 common DeGeorge syndrome, which can cause sagittal and urine coronal synostosis. Mendelian disorders, like you have FGFR2 related disorders, multifactorial. It is believed that many of the non-syndromic sagittal synostosis could be multifactorial. How to understand in its simplest way? Imagine this C-link as the DNA molecule and the pillars are your genes. So if there is a small crack in the large pillar, the bridge may collapse. That is akin to a single gene disorder, monogenic disorder, a gene which is essential for the functioning of the tissue or the organ system or the organism itself. When damaged, can lead to severe disorder. Whereas if there is a small crack in one of the smaller pillar, you may not be concerned. 2, 3, 4, 5, the bridge may collapse. This is akin to a multifactorial disorder where mutations in different genes act in concert to produce a susceptibility. Under the influence of an environmental insult, it produces a disorder. And if there is a tsunami or a terrorist attack, the entire C-link is gone, where you have genes of large effect size and small effect size are gone. And genes on the DNA molecule are not spread as per the system. Chromosome 1 for neurology, chromosome 2 for neurosurgery. It's not like that. So they are like the genes of eye development can be next to the development of the heart and so on. So once multiple genes are deleted or duplicated, it causes chromosomal disorders. So what are the common mutational mechanisms? The change in the chromosome number itself, that is aneuploidy, Down syndrome, and Turner syndrome, which can cause craniosynostosis. Taking just the arbitrary segments on the chromosome, where say A, B, C, D are there. These are arbitrarily divided. And if one of them is deleted, it's called a copy number loss. And if it is excess, copy number gain. So all of us have copy number variants in our genome, but most of them are in gene poor region. So none of us suffer from any adverse consequence. Whereas if it is in a gene-rich region like 22q11, where more than 30 genes are there, you develop a chromosomal disorder. Coming to the nucleotides per se, we have 4 nucleotides and 3 letters code for a amino acid, that is codon. If any change can cause silent missense and nonsense mutations, or change in the reading frame can cause disorders. Ultimately, repeat disorders is not so important for craniosynostosis. So how do we evaluate in our clinic? So we take a very detailed history, antenatal history, especially about the maternal and paternal age at conception. So advanced paternal age we often see in many of the sporadic cases of FGFR syndromes. Any pregnancy complications, teratogen exposure, or bicornuate uterus, and so on, which can explain some plagiocephaly or something. Then a detailed developmental history, so which will tell you whether the brain development is normal or abnormal. If it is normal, often it is non-syndromic craniosynostosis. And then signs and symptoms of raised ICP, as we discussed, airway concerns like snoring, sleep apnea, vision, hearing impairment, whether it is conductive or sensory neural. And then recurrent LRI may suggest undiagnosed heart disease, especially septal defects. Then the most important is the 3-generation pedigree. It will tell you, like Professor Dhaval showed, a mother and 2 kids. So it's a vertical transmission that is autosomal dominant disorder. And sometimes it is a sporadic condition where parents are normal and no one else is affected. It's mostly autosomal dominant de novo or dominant with reduced penetrance. And sometimes when there is consanguinity and multiple siblings are affected, it is recessive, such as Carpenter syndrome and so on. So coming to clinical examination, detailed anthropometry is extremely essential. The head circumference, limb length, arm span, and so on. And head-to-toe examination, just show you few of the things. You have to describe the shape of the skull. So these terminologies are available in ACMG. What is the accurate terminology? So many are presented here: dolichocephaly, plagiocephaly, acrocephaly, clover-leaf skull, and so on. So if you have a scalp defect where there is a furrowed skin, cutis gyrata, it is Carpenter syndrome. This is what is cutis gyrata. This is how it looks like. If there is a harlequin deformity of the palpebral fissure, you know that it is unicoronal synostosis. Then there could be proptosis, low set ears, other ear anomalies, weak nose or a prominent nose with prognathism, which suggests FGFR related disorder. High palate is often involved with all the craniosynostosis syndromes. Sometimes it's called Byzantine palate or Gothic palate. We just say high palate. Then there could be oligodontia or excess, that is crowded teeth with supernumerary teeth. So that suggests few syndromes, as sir was telling, interleukin 11 related disorder. There could be short neck and pectus abnormalities. There could be limb abnormalities like the mitten hand that is commonly seen in Apert syndrome, or there could be the broad thumbs, brachydactyly, and broad toes with carpotarsal synostosis, which can be there in the Pfeiffer syndrome. Continuing with the multi-sutural craniosynostosis with dysmorphic features. You can see, I hope you can see, all of you can see postdactyl, polydactyly, brachydactyly, and polysyndactyly. That's Carpenter syndrome. And if you have coronal and metopic ridging with agenesis of the radius or radial ray defects, thumb is absent here, Ballard-Gerard syndrome. So you take head to toe careful examination, piece them together with the overall features, you come to a diagnosis that's mostly a syndromic one. Apart from that, you need to do thorough systemic examination and few investigations. Screening for metabolic disorders is essential to rule out secondary causes. MRI brain, especially when when you suspect CNS malformation, seizures, or raised ICT, and the other abnormalities. Of course, CT and visual hearing assessment. Apart from fundal examination, VEP, BERA can be done. Dental assessment, echo, ultrasound abdomen and pelvis to rule out genitourinary malformations and renal malformations. So, how do we test for craniosynostosis? This in the traditional genetic testing in the textbooks. Whenever you suspect craniosynostosis, we were taught to see whether it is associated with multiple congenital anomalies, ID, dysmorphism, growth delay, developmental delay. Likely it is a chromosomal disorder, you go ahead with chromosomal testing. So karyotype testing when you suspect aneuploidies such as Down syndrome and Turner syndrome. or if it is otherwise fish MLPA or microarray, most commonly microarray. After 2011, everyone is using microarray. When you suspect deletion syndrome, copy number variations, that is 22q11, 9p, 11q deletion syndromes, which are associated with craniosynostosis. But if you employ microarray, the overall diagnostic yield is only 8%. Whereas when you suspect either there is a clear-cut inheritance pattern, recognizable syndrome, or a non-syndromic craniosynostosis, most likely they are Mendelian, and either you decide on single gene testing or panel testing. Single gene testing, when you have a case of Apert syndrome or Crouzon or Munke, then very few exons of FGFR1, 2, 3, and twist1 can be done, and you can get a diagnosis. If none of these are there, you can go for a panel testing, which can give you a diagnostic yield of around 20%. But after 2021, what is the recommendation of American College of Medical Genetics? For all cases, syndromic cases, utilize exome sequencing, and that's what we are doing. And I'll tell you how it is more useful. So most ideal is trio, that is father, mother, and the child, trio or quad exome sequencing. Or if the prices are prohibitive, then you can use singleton exome sequencing with Sanger testing of the parents. If it is negative, whole genome sequencing. So when you look at literature, the overall yield is about 35%, and most often the yield is in with the syndromic craniosynostosis, that's about 62%, than 6% in non-syndromic cases. Just to show you how exome helps this child, again with no developmental problems, presented with the poor vision. You can see the dysmorphic features we discussed previously, and you can see that multiple sutures are synostosed, and exome sequencing showed FGFR2 related craniosynostosis. Now it's like in genetics we have what are called lumpers and splitters. So earlier the earlier medical genetic professors were splitters. They would split, this is Crouzon, this is Apert, this is anti-Blixer, and so on. Now we lump it into a gene, because the same gene can cause different disorders, and many of these symptoms overlap. So we call it as FGFR2 related craniosynostosis. So in this case, 3-year-old female, one of consanguineous parentage, abnormal shape of the skull, drooping of eyelids, and there was no developmental delay, visual hearing impairment. And as you can see, there was bilateral lambdoid and the right coronal synostosis. Okay, so suspecting a complex multisutural craniosynostosis with asymmetric ventriculomegaly, that was the only history given to us. We did exome sequencing, and it was a homozygous pathogenic variant in colectin, which causes what is called 3MC3 syndrome, which is actually a clefting syndrome. We didn't have that information in while testing. So it causes commonly cleft lip, cleft palate, or velopharyngeal insufficiency at least. So exome sequencing could tell us the diagnosis of this rare syndrome, and we could revisit the phenotype. So another case, just to show how exome helps, that this mother was pregnant at 3 to 4 months and came with this history with the presentation. This is a common clinical presentation of unilateral coronal synostosis. There was no developmental delay or anything, and the diagnosis was Munke's syndrome. This is the commonest mutation that causes Munke's syndrome, only mutation that causes Munke's syndrome, the proline 250 arginine in FGFR3. But this helped us to counsel the parents about the recurrence risk in the next pregnancy. The trio is the best. It gives you answer immediately. So this child presented with congenital heart disease, malformations. MRI brain was normal, but there was autism and developmental issues. And the child had de novo mutation in a gene called ADNP, and recently ADNP has been associated with craniosynostosis. Exomes also help in rephenotyping. This is an interesting case, 19-year-old male presented with developmental delay, abnormal skull shape, morphinoid habitus, and progressive proptosis. You can see this one, there is Chiari with syrinx, cervical syrinx, and multisutural synostosis. In fact, because of the Marfanoid habitus and cherry malformation, we suspected Crimson-Goldberg in the clinically, whereas the answer came as interleukin-11 RA-related variant. So we could revisit the phenotype, even though Marfanoid habitus has not been explained, and mostly they will have brachydactyly rather than long fingers. So it can, this is called reverse phenotyping. Exome sequencing helps you to revisit the phenotype, or it could be phenotypic expansion. So it can also help in detecting CMEs. This is a case of 22q11 deletion, which was diagnosed by West. So please don't be under the belief that array is the only test for copy number variations. Exome sequencing is very sensitive, even detecting copy number variations, thereby making array obsolete. So after seeing these many cases, there are certain terminologies one should know. What is called locus heterogeneity, where mutations in different genes can cause same phenotype. So here, patient 1 and 2 both have Pfeiffer syndrome. One is Pfeiffer 1 and Pfeiffer, the other is 2, with floor leaf skull, with developmental issues. And as you can see, patient 1 has FGFR2 related illness, and the patient 2 has FGFR1. Clinically, we were not able to say which gene it is. This is called locus heterogeneity. And there could be something called phenotypic heterogeneity, where the same gene can cause multiple different craniosynostosis syndromes. Here, FGFR2 has so many syndromes: anti-Bixler, Appert, Beres-Stevenson, bent bone dysplasia with craniosynostosis, Crouzon, and so on. So if you look at genotype-phenotype correlation, that these two mutations, only these two mutations are associated with Beres-Stevenson. If you have those two mutations, you can clinically call these kids as Beres-Stevenson. And if it is these two mutations, 381 and 391, they are bent bone dysplasia, and you can, phytogram or babygram can say show the bent bone, bent femora and tibia and so on. So what is pleiotrophy? Pleiotrophy is mutations at different locations of the gene causing multiple organ dysfunction, sometimes unrelated organs. So the current concept is more oligogenic, that it is not monogenic disorders. Most disorders are oligogenic, that multiple genes interact. So this is an example of digenic inheritance of craniosynostosis, especially for sagittal synostosis, non-syndromic, where you have mutation in SMART6 gene, and which is a rare variant, and you have a common variant in BMP2, that is a bone morphogenic protein 2. So if both are inherited together, then it causes sagittal synostosis because of increased SMART signaling. If anybody inherits only one of the mutation, they will never develop the disorder. So often what we see is one of the mutation is inherited from father, one of the mutation is inherited from the mother. So parents are fine and the child will have the disorder. So this is called digenic inheritance. Then a few terminologies: penetrance and expressivity. That so I have taken the example of TCF12, which causes again non-syndromic craniosynostosis, sometimes syndromic, and it has a 50% penetrance. What does it mean? If there are 100 individuals with the mutation, how many of them develop the disease? How many of them even show a single feature of the phenotype? That is called penetrance. If 50 of them develop, then it's called 50% penetrance. If 68 of them develop, it is called 68% penetrance. So as you can see, many of these non-syndromic synostosis are less penetrant, usually 50 to 60 penetrant. And sometimes the mother, as sir showed, mother may have a milder feature, whereas kids have very severe feature with the same mutation. This is called variable expressivity. It is the which can explain intrafamilial and interfamilial variability. Now, the most recent one is the somatic variation. Geneticists are understanding that somatic variations also cause syndromic synostosis. And one example is somatic mutation. That is, it is not there in all the cells of trillion cells of the body, but few cells. SMO gene, which causes Curry-Jones syndrome, which causes craniosynostosis, small rotation, congenital heart disease, and so on. Then again, with advancement in genetics, multiple new genes have been associated with syndromic craniosynostosis. For example, one new syndrome is NFIA-related macrocephaly with craniosynostosis syndrome, and so on. I'll not go into the details. So finally, we have understood that short read sequencing has many limitations which we are employing regularly, and it causes, it cannot detect repeat expansions, structural variations which can cause craniosynostosis, methylation problems, and so on. Just to show you one slide where this is, the short read sequencing which failed to pick up this variant, but long read could. So there can be gaps or such low mapping quality, which was picked up by long read sequencing. So we have started doing long read sequencing. So this will tell you epigenetic alterations also. So using long read sequencing and functional analysis, you can reach a higher diagnostic yield, more than 60 to 70%. So this is just one last slide showing what we have done at our clinic, at our lab. We had about 61 patients over the last 5 years with suspected craniosynostosis. Many of them did not consent early, especially in the COVID time period for genetic testing. But whoever did, we had a diagnostic yield of nearly 59%. Most of them were syndromic, and this was this pattern of pathogenic variants in different genes in our cohort. So I'll be happy to take any questions. I thank Professor Dhaval, Dr. Swaz, and the team for the invitation. Thank you.
Thank you, Gautam, for that really very lucid talk on genetics. Like we revised what we learned, and we learned what we did not know. So one important message is that can be mismatch between genetics and phenotype. So just one abnormal gene or abnormal report, do not label the child. This is for your clinicians. Well, this is very common. It happens. It's a blemish, like to be called as Crouzon syndrome, FGFR, but that may not have anything to do with the phenotype. So these are the one issues with genetics. So always consult clinical genetics before you talk to parents. So it's good practice to refer to genetics not only for testing, but for counseling as well. So they talk to the parents. Otherwise, just you read the report, you feel, okay, my baby is gone now. So next talk is on radiology of craniosynostosis. I just briefly covered about radiology, but we have Dr. Sabha. She is an assistant professor of neuroradiology at NIMHANS. So she will be talking on radiological evaluation of craniosynostosis. Sabha, welcome.
Thank you, sir. So I have no disclosures, but I will say that Dhaval sir covered pretty much everything I have to say. So this is just going to be a reinforcement of what sir has already discussed. I'm quite envious of the collection of cases you have, because we just have the radiology, but we have the clinical correlates as well. So I think the audience will have a good understanding now that you've showed the clinical aspect. So as we all know, essentially craniosynostosis is the premature fusion of one or more cranial sutures. So the incidence is about 1 in 2,500 infants. I will go through the morbidity aspect later, and it has already been covered extensively by Professor Shukla. But in terms of what's really driving the force of craniosynostosis, we essentially have two sets of thought here. So initially we had the Virchow's law. We are all aware of this. So essentially what it says is that the cranial growth restriction will occur in a plane parallel to the premature fused suture, as opposed to the growth of the brain that occurs perpendicular to that. And as we all know, only the metopic suture could be fused before 9 months of age. So essentially, it so happens that you have spicules of bone growing towards each other, and that's precisely where the formation of sutures takes place, at the site of meeting of the osteogenic fronts. So the sutural fate is also determined largely by the dura mater. It goes hand in hand, and it is also a complex interplay between osteoblastic as well as osteoclastic activity. So anytime there's a defective dura, it's pretty mandate to find an absent suture or a fused suture in those cases. So like I said, it's a right balance of proliferation, differentiation, and also migration, which is essential for sutural patency. I think Professor Gautam has gone through extensively in terms of the genetic evaluation and also the environmental factors that could dictate the development of craniosynostosis. And then we have the Moss theory. So this is of more interest to me because it makes more sense in terms of radiology. So the neural mass expansion is really what perpetuates the capsule expansion, the neurocranial capsule expansion. And as we all know, synostosis per se is an early embryologic event. Dysostosis of skull bones affects the form as well as the spatial relation, and altered location as well as tensile forces at the site of attachment of the dura, particularly at the crista gali, the sphenoid bone, the petrous apices, as well as the overlying cranium, calvarium dictates sutural, fusion. So this is a picture of Moss, and this is precisely what he described, that the expanding bone is what will perpetuate the expansion of the neurocranial capsule. The expansion of the eye will, lead to the formation of the expansion of the orbit. And then you have the tensile forces rendered by the contraction of the muscles, particularly the temporalis, the stylohyaloid, as well as the sternocleidomastoid, which result in the molding of the facial region. So in terms of where exactly at time points where exactly the sutures could be found to be fused. So essentially we have the metopic suture, which fuses the earliest between 6 to 8 months, followed by the sagittal suture. And then from lateral to medial, we come for the fusion of the other sutures, primarily the lambdoid suture being the last. So in terms of how we know that a suture is fused, so a suture precisely will show the sawtooth margins, the serrated margins. So in process of fusion, we see the absence of the serrated margins, and it progresses to forming this linear. It progresses to form this linear course, and finally it's completely fused. So in terms of what really is the pathophysiology of craniosynostosis, we have the primary and the secondary. Primarily being triggered by developmental errors or intrinsic genetic causes. Secondary could be perpetuated by underlying metabolic abnormalities such as rickets, hypocalcemia, hypophosphatasia, etc., as well as hematological disorders. In terms of percentages, 85% of what we encounter in clinical practice are non-syndromic, as opposed to 15%, which tend to be on the syndromic side. Much like that, most of the non-syndromic cases tend to have fusion of a single suture, as opposed to the syndromic cases that have multi-sutural involvement. So the most common of these would be the sagittal suture, followed by the coronal, metopic, and lastly you have the lambdoid suture. So this is just a renderation of the sutures. In particular, you have the anterior fontanelle, followed by laterally you have the coronal suture, and then you also have the metopic suture, which essentially runs from the glabella to the anterior fontanelle. And posteriorly, you have the posterior fontanelle, which is depicted by white, and you also have the sagittal suture depicted in orange, and the lambdoid suture. So on the lateral aspect, as is depicted here, you have the pterion, which is depicted in green, which is the sphenoidal fontanelle. And then posteriorly, you have the asterion, which is a posterolateral fontanelle. In between, you have the squamosal suture. And lastly, you also have the spinofrontal suture. At the skull base, we have the spheno-occipital synchondrosis. Laterally, we have the petro-occipital synchondrosis. Posteriorly, you have the anterior intra-occipital synchondrosis. Posterolaterally, you have the occipitomastoidal synchondrosis. And then right at the back, you have the posterior intra-occipital synchondrosis. And in the middle, you have what is known as a Kirkring's ossicle. So again, for me, in terms of understanding why, certain sutural abnormalities also present with midfacial hypoplasia has a lot to do with understanding of the embryology of skull. So as is demonstrated here, the frontal sphenoid as well as the squamous temporal bone emanate from the neural crest. So they are derived from the neural crest cells, as is the frontal complex. So anytime you have, dysostosis affecting these set of bones, you are most likely to encounter midfacial hypoplasia as well. In contrast, you have the parietal, petrous, temporal, and occipital bones, which emanate from the paraxial mesoderm. So this is just an overview of the major non-syndromic craniosynostosis. When it comes to imaging, I think there's been a paradigm shift now, because we do tend to get an MR in certain cases, but it essentially just started with your plain radiograph and then moved on to low-dose craniofacial CT. So in these cases, the the MAS is fixed, because we know these are tiny kids and we really can't expose them to a lot of radiation. So we have this fixed protocol of 50 milliamperes and 80 kilovolt, which is not too high, and you also get thin reconstructions with 0.6 to 5 mm thickness. So what is a radiologist's role per se? We evaluate the head shape and also confirm the synostosis in terms of what I showed. When there's a reduction in the serration, linearity, perisutural sclerosis, as well as complete absence of suture in some cases. And preoperative planning is also important, particularly for the venous structures that we encounter in close tandem with the calvarium. Post-operative complications in terms of looking for hemorrhage, are there any CSF leaks, and if any venous structures have been damaged, or thrombosis of these veins, in addition to restenosis of sutures. So this is just a reiteration of what was already extensively covered by Dr. Shukla. So this is a case of sagittal craniosynostosis. As you can see, there's absolutely no evidence of the sagittal suture, and there's occipital bossing in this case. And as you can also see, there is this endosteal scalloping which occurs in the posterior aspect. Now, this is again a telltale of scaphocephaly as opposed to what we will see in trigonocephaly. So if you can imagine a boat, so this is precisely how an elongated boat would look to a radiologist. And you also have the prominent forehead. You could have developmental delays as well due to the restricted growth of the neuroparenchyma. Now, what's more important for the surgeon would be to trace the cause of the veins, particularly the superior sagittal sinus, if there's a presence of any large veins or bridging veins, and also any telltales of raised intracranial pressure. So this is the infamous, the Harlequin sign, which occurs in cases of unilateral coronal craniosynostosis. So as you can see here, there's an asymmetry in the forehead. There's flattened forehead on the side of the fused suture, and the contralateral side appears to be slightly elevated. You also see this elevation of the superior orbital rim, which essentially contributes to the sign of the Harlequin. And like Professor Shukla mentioned, there is also the deviation of the nose towards the affected side. So this is a case of bilateral coronal craniosynostosis. Now, this is a red herring for most radiologists, because we know that anytime you have bilateral coronal craniosynostosis, we are dealing with a syndromic case as opposed to a non-syndromic case. So in addition to that, I think it makes sense that when there's fusion on either side, there's stunted growth of the brain. There's also a broad skull, and more often than not, you will find telltales of raised intracranial pressure in such cases. So this is again something that I wanted to show in terms of what you see in scaphocephaly. You see the endosteal scalloping on the posterior aspect, whereas in the case of metopic craniosynostosis, you see the omega sign in the anterior aspect. And this is in contrast to what Sir showed in metopic ridging, which is a relatively benign entity which may or may not be treated in terms of the clinical presentation of the child. So here you see the bony spur as opposed to the scalloping that you see in the case of craniosynostosis. So this spur essentially contributes to the M sign, whereas you have the omega sign where you have scalloping on the inner aspect of the calvaria. Again, cases of metopic craniosynostosis are notorious to be associated with syndromes, some of which have already been covered extensively in the previous lecture. Lastly, we also have the lambdoid craniosynostosis, which contributes to the posterior plagiocephaly. So, in addition to what we saw, where there's absence of suture, there's also relative flattening of the bone on the affected side, and on the countercoup side, you have frontal bossing. You also see the foramen magnum, which is deviated towards the side of the sutural synostosis. And if you were to draw, along the perimeters of the calvarium, you would essentially trace a trapezoid structure. So this is, to a radiologist, this is how we would differentiate between a posterior plagiocephaly versus a positional plagiocephaly, where the inciting agent is basically caused by by an external positional force or a deforming force, which became quite common, in the previous times when kids were, I think this was also covered, where the kids were actually put back to the sleeping position. So as you can see, if you were to draw a line across the perimeter of the calvarium in cases of positional plagiocephaly, you would essentially draw out a parallelogram. In addition to that, you see the earlobe being displaced anteriorly in the cases of positional plagiocephaly on the side where the suture is fused, as opposed to posterior plagiocephaly where there is actual craniosynostosis, where the earlobe is displaced posteriorly. In terms of what I report, now again, I think I've mentioned it several times. We need to look for multisutural fusion if there's any anomalous cause of, the draining venous sinuses. In cases of stenosis, we are well aware of the fact that there's collateral formation. Again, we need to mention that. Is there any anatomic arterial variant? Do we see any associated craniovertebral junction anomalies, particularly Chiari malformation and any telltales of raised intracranial pressure preoperatively? Post-operatively, we look for signs of hemorrhage, stroke, jugular vein obstruction, any kind of collection in the cranium that could be contributing to mass effect hydrocephalus, as well as displacement of the bone growth material, graft material. I will not be covering syndromic synostosis. We had a pretty concentrated lecture on that before this. But just a reinforcement of some of the common syndromic entities. In the case of Apert syndrome, more often than not, at least in my clinical practice, I have come across these syndromes to be associated with pansutural craniosynostosis. Now, this is a case where, again, we can appreciate the harlequin eye and also the anterior fossa, which appears to be short. In addition to that, when we perform the skeletal survey, you will come across syndactyly, particularly in Apert syndrome. And this is another case where there's classic telltale of raised intracranial pressure, where there is brachycephaly and essential opening of the widening of the metopic suture secondary to raised intracranial pressure. In addition to that, you also appreciate the maxillary hypoplasia here. In cases of, again, Cruzon syndrome, like in this case, we see there's bicoronal craniosynostosis, and also there's a unilateral lambdoid craniosynostosis, in addition to having midfacial hypoplasia as well. And we also can appreciate the presence of hypertelorism in these cases. And intracranially, again, we have evidence of raised intracranial pressure in terms of the small posterior fossa and also the prominent ventricular system. So in cases of multisutural synostosis, we know by now that it is syndromic and it could be associated with a gamut of sutures that are fused. We have some examples here, and this is the infamous Kleebert-Skatel skull, where because of premature closure of the sagittal coronal as well as the lambdoid suture, there is wasting at the temporal region, and there is expansion at the temporal regions, as is seen here. The patients could present with severe proptosis as well as telltales of raised intracranial pressure in the form of hydrocephalus, and clinically could also have intellectual impairment. Now, again, this is very commonly seen only with the syndromic cases. This is another entity which is known as the oxycephaly. So as you can see here, the synostosis of the sagittal as well as bilateral coronal as well as a metopic suture. So you have this anterior aspect of the cranium that tends to be towering and more profound as opposed to the rest of the calvarium. We also have this Mercedes-Benz sign. We as radiologists are just obsessed with signs. So again, one of the signs where you see, the fusion of the sagittal as well as the lambdoid suture. So that contributes to the formation of the Mercedes-Benz sign. Now, as I previously mentioned, there's been a paradigm shift in terms of what we can offer to the patient, particularly to reduce the radiation, since most of these cases would mandate follow-up imaging. So initially, it just started off with ultrasound, and then we just relied on run-of-the-mill radiography and low-dose CT. But now we also have MR. So MR is essentially a non-irradiating technique. But what's important for us to know is we need to sedate the patient. And sedating the patient is not always good, particularly because these are pretty long scans. And again, the quintessential run-of-the-mill sequences won't help you in terms of really looking at the bone. But we do have the black bone MR, which is not available at most of the centers. But if we could apply that and have it available at most of the centers, that could be a welcome shift in terms of what is offered imaging-wise to the patient. And again, there has also been this application of perfusion sequences in terms of how the patient improves radiologically pre and post imaging. Now, for that, we need professional expertise, particularly when it comes to the post-labeling delay. That, again, may not be available everywhere. And also, there's longer data post-processing, particularly when it comes to these fancy sequences. So this is how it started off, particularly on ultrasound. So as you can see on the 3D rendered reconstruction, there is partial fusion of the sagittal suture. Now I say partial fusion because I have, particularly in this case, the probe has been placed at points B, C, and D. Now, as Sir mentioned, anytime there is sutural fusion, you see the hyperechogenicity, and that is in continuum to this linear structure which you see in C here. But where it is placed, closer to where the suture is open, you see this hypoechogenicity and this discontinuity in the hyperechoic line. So that again is an ultrasound evidence of sutural fusion. So black blood imaging is a recent application which shows great promise in terms of actually helping the surgeon mapping the cranium as well as the intracranial abnormalities, particularly the parenchymal abnormalities. Is there any telltale of raised intracranial pressure, and also mapping the venous system. So for any radiologist or a radiology enthusiast, we know black blood MR is basically a short TR as well as a low flip angle. It basically means that we are acquiring the sequences super fast. So when you look at the brain parenchyma, the contrast is not as great, but you're able to pick on the calvarium. So this is one of the recent studies which essentially looked at the application of black bone MR when it comes to mapping the cranium. So as you can see here, the course of the superior sagittal sinus is also well demarcated, and we have essentially concentrated on the frontal region for the purpose of preoperative planning. More important to us would be, again, looking at, venous outflow obstruction. So it can occur due to primary bone disorder. As Sir already mentioned, there could be stenosis, jugular vein stenosis happening here. And secondary to that, you have the formation of the collaterals as well as, multiplicity of emissary veins. So this is an example of a case where preoperatively you don't see the transverse sinus, you don't see the sigmoid sinus. However, the vein of Labbé is patent on both sides. So 1 month after the operation, as is seen in the middle image here, there is the resurgence of multiple cortical veins, and you also see faint, albeit some kind of flow-related enhancement at the level of the sigmoid sinus, and also the patency of the vein of Labbé, where it is essentially opening at the transverse sigmoid junction. Now, cut to chase, 6 months later, you have this profound appearance of cortical veins as well as the rest of the venous sinuses, which is a lot better than what it was to start with. So one of the applications that we are trying to study at NIMHANS per se is whether or not these patients are going to improve in terms of the perfusion. So again, there's a lot of debate as to what is really contributing to the decreased perfusion to start with. It could be that, there's restriction to the growth of the brain, or you have venous hypertension, which is essentially contributing to decreased perfusion of the brain parenchyma. So this is one of, the cases done outside, where essentially preoperatively you do see the diffuse hypoperfusion, particularly when it comes to the cortices. And 6 months post-surgery, you have the resurgence of perfusion, particularly again in terms of cortical perfusion. So one of the other, rather less fancy technique would again be to look at FA. So if the FA is already low, fractional anisotropy is low to begin with, there's nothing much you would obtain, particularly post-intervention. So this is important in terms of prognosticating. So if the FA is low to begin with, there's nothing more you will be contributing in that particular region. However, there are other, clinical telltales as well in terms of how the baby would, improve post-surgery. So we looked at the calvarium, we looked at the brain parenchyma. So in brain parenchyma, like I already mentioned, you could have malformations of cortical development. You could also have corpus callosal abnormalities. Now again, you look at the size of ventricles here, and if there's any crowding of the posterior fossa as well as tonsillar herniation. So as you can see in the image above, there is tonsillar herniation, but you don't see any evidence of hydrocephalus. Whereas in the image below, there is tonsillar herniation. There's also evidence of supratentorial ventriculomegaly as well as syringomyelia. So this is an in-house case. So as you can see, pretty much every suture is fused here. So there's craniosynostosis. Now again, what we see on CT is, there's some amount of platybasia happening. There's also AAD. So this essentially can be replicated on MR. Now, in addition to the signs of, particularly when it comes to the signs of raised intracranial pressure, you do see the endosteal scalloping happening at the inner aspect, the inner table of the calvarium. And on MR, you see the signs of raised, again, other signs of raised intracranial pressure in terms of prominence of the optic nerve sheath. And you do also see telltales of hypertelorism here. So lastly, when it comes to perfusion, sorry about that. When it comes to perfusion, with particularly the cases that I have gone through, we haven't really come across cases where there is reduced perfusion to start with. This is again important in terms of reinstating that one of the previous studies I showed, they did have a significant hypoperfusion to begin with, but you could also have cases where, the brain growth is pretty fine. And although there are telltales of raised intracranial pressure, you could have absolutely normal perfusion of the brain parenchyma as well. So again, this is a case of pansutural craniosynostosis. As you can see here, in addition, this is essentially black bone imaging. So as you can see here, in addition to being able to, map out the calvarium, you can also appreciate the appearance of the intracranial structures. So previously, it so happened that on CT, we were only looking at the cranium and then performed MR to gauge what's happening inside the cranium. But now with this particular sequence, you hit two birds in one go, where you're also mapping the cranium and you're also looking at what's happening inside. So as you can see here, the tonsillar herniation and also the presence of syringomyelia is quite evident on this one sequence itself. And you also see the presence of emissary veins here, which is seen in the retrocerebellar region. So I just wanted to show, how precise black bone imaging is with respect to the gold standard, which is your quintessential run-of-the-mill CT. So as is pretty evident here, you see the scalloping of the inner table of the calvarium, which is well appreciated on CT as well as black bone MR. Of particular importance to me would be mentioning, if there's actual presence of emissary veins traversing through these lacunae, and as can be visualized on the black bone MR, those are much easily picked because you have the bony contour as well as the traversing venous structures, as opposed to CT, where I could have, particularly in the transverse sigmoid junction, I could also call it an arachnoid granulation. So this is another case of syndromic craniosynostosis. Now there's a multiplicity of findings here. So you do see some degree of supratentorial ventriculomegaly, you do see tonsillar herniation, there's syrinx happening. Now, in addition to that, I did mention that arterial variants could also be present in these cases. So now, why precisely I wanted to show, the skull base synchondrosis is because in occurrences of craniosynostosis, you also have skull base abnormalities. So one of the consequences of skull base abnormalities would be this aberrant cause of the ICA. So as can be seen here, the cavernous segments of IC are inching towards each other. This is what we call the kissing carotids. So in terms of how the patient could present, it may not be of great consequences, particularly because we haven't really seen arterial ischemic strokes in such cases. But again, this is something that to be kept in mind, that you could have arterial anomalies as well. In addition to that, of course, you have venous anomalies. So as you can see, you don't see the appearance of the transverse sigmoid junction on one of the sides, and on the side where there's the absence of the transverse sinus, you see this beautiful serpiginous structure, which is basically a bridging the draining emissary vein. Lastly, again, like I said, you do need to concentrate on the midfacial region, particularly in cases of, trigonocephaly. And again, look at the orbits. Are there any signs of papilledema, raised intracranial pressure? And, if there is hyper or hypotelorism. Hypotelorism, again, like sir mentioned, is common in cases of metopic suture dysfunction, as opposed to hypertelorism, which is common in other sutural abnormalities. So in conclusion, anatomy is crucial. Low-dose CT has been the workhorse, but there's going to be a welcome change, particularly with respect to the application of black bone MR in terms of complementing the calvareal abnormalities with the intracranial abnormalities as well. parallelogram shaped skull is what is going to help you differentiate between positional plagiocephaly as opposed to posterior craniosynostotic plagiocephaly. And if there is occurrences of multiple suture involvement, we always are on the side of syndromic craniosynostosis, and in those cases, it is important that we rule out any telltales of raised intracranial pressure.
So it was quite a comprehensive lecture on radiology of craniosynostosis. So this advice for residents that when you send a child to radiologist for diagnosis, don't just send an empty form. Please write some clinical details because they are clinical radiologists. So only in presence of clinical details, they will be able to report properly, and they will be able to add additional sequence if required, depending on the clinical needs of the patient. So this is what every one of us should make sure that we write enough clinical detail before we ask for radiological evaluation. So thank you, Sabha. Now I'll that finishes our evaluation portion. Now coming to the treatment portion. So next talk is on the tools of the trade. So I will just brief you about the history of craniosynostosis surgery at Midface. So Dr. Arun Mohanty started craniosynostosis surgery in late 1990s when I was still a resident. And that's how I developed interest in craniosynostosis. So once he left for US, Dr. Dwarkanath, who came from AIMS with a large volume of pediatric neurosurgery setup, he started this current modern craniosynostosis program. And later I joined him. Now Dr. Subhash, who is our course coordinator, he is one of the leading craniosynostosis surgeons at our institute. So Dr. Dwarkanath is a professor of neurosurgery, and he was former head of the department of neurosurgery before me. And I request Dr. Dwarkanath to talk on tools of the trade, like what are the implants, materials used for surgery for craniosynostosis. Dwarkanath, please.
Thank you, Dr. Dhaval. Make me sound older than I am. Anyhow, what Dr. Dhaval said, we developed interest in craniosynostosis thanks to Dr. Mahapatra. And that continued. So after Dr. Mohanty left, it had almost stopped. So I started in 2006-07, and then Dr. Shukla joined in 2009. And it's very nice to see the youngsters now, Subhash, Nadeem, Harsh, Ninad, all of them take a active interest in operating these cases. But one thing where the surgery has changed is the instrumentation. When we were residents, all we had was steel wires and stainless steel mini plates and screws and threads. And that's it. But over the past many years, first the titanium mini plates and screws came, then the absorbable plates and screws came, and now we have distractors. So the surgery itself has evolved over the last 2 decades, especially in the last decade where we've had distraction osteogenesis becoming more and more common. And then, of course, the introduction of endoscopic surgery also. So I'll just quickly okay. प्रेजेंटेशन खोलो और शेयर स्क्रीन वो आ जाएगी इसका Zoom open here, इसमें Citrix open है. So like I was saying, the instruments itself has undergone a sea change. The surgery of craniosynostosis is in principle very simple. You have a malformed head. I mean, this is the standard craniosynostosis, not the areas where there's raised ICP and all that. The whole idea is to basically remodel the bone in such a way that the patient has a good cosmetic outcome, and over a period of years, as the bone heals, as the brain grows, you give enough space for the brain to go symmetrically and help the skull retain a normal shape. Yeah. But there are a few things which you need to be careful about. One, and the most important thing, is to minimize the blood loss, especially in dilated scalp, especially from the dilated scalp wounds. We've had blunders, and we have stopped using adrenaline for the infiltration. We lost one patient because adrenaline went directly into the dilated scalp veins, and the patient collapsed on table. So right now we use just lignocaine injections while opening the skin flap. We shifted again over from the knife to the Colorado monopolar cauteries to raise the skin flap. The skin flap, again, there is a difference in how surgeons raise the skin flap. Some people, like me, prefer to raise the periosteal flap separately because I believe that periosteal flap has a osteogenetic potential over the next few years. But there are people who do not raise the periosteal skin flap and just outline the bone cuts with the periosteum in situ, and then do the skin flap. The whole idea is when you are doing skin incision, of course, being zigzag, so that it gives a good cosmetic result. The whole idea is when you're doing these flaps is to make sure that you mark more correctly and use the osteotome or the craniotome to take out the skin flaps properly. So you, like I said, I take periosteal flap. These are some of the instruments. You need to be very careful. Again, dislodge the supraorbital nerve from the foramen. Either you convert that, if it's complete, you have to break open the bone and then dissect the nerve out. Like this. So once that is, then you do the separate the periorbita. The trick again is if you maintain the periorbita intact, the postoperative orbital swelling is less. If you don't do it, the orbital swelling becomes quite significant postoperatively and the patient is quite uncomfortable. So the idea is to keep the periorbita intact as much as possible. Then you proceed with the craniotomy. Of course, in the olden days, we used to the giggly saw, then came the drills. So with a mixture of drills and Kerrison rongers, the craniotomy is done. So unlike the standard craniotome where we use a perforator to make the burr-holes, so the bone is very soft. So use a diamond drill to make the burr-holes, and then use the craniotome to take out the flaps. Then comes the frontoorbital bandeau. The frontoorbital bandeau, the principle is that you take out a good chunk of the bone along with the frontoorbital bandeau, and this is what is going to demonstrate the postoperative cosmetic results the maximum. So, so this is the frontoorbital bandeau. Once you raise the frontoorbital bandeau, now you have to reshape this. So depending on whether the patient has metopic stenosis, whether the patient has brachycephaly, whether the patient has any other abnormality, plagiocephaly, so you need to reshape the bandio accordingly. So the easiest thing is to first have a three-dimensional image as to how you are going to reshape the shape of the skull, and then multiple green stick fractures on this bandio, and then fix the bandio in that position using absorbable plates and screws. So you get a very nice shape of the frontoorbital bandio. And if the patient also has hypertelorism, then you can actually decrease the shape of the bandio. You can cut the bandio, take out some bone, and then decrease the intercanthal distance. And then you reshape the bandio, and then you fix it using absorbable plates and screws. These absorbable plates and screws have been a huge boon in the last decade or so. They work on the principle that, you need fixation only for the first few months. After the bone takes over, you need to heat the plates before you actually shape them. And these can be shaped multiple times. So every time you heat them, it becomes soft. Then you can reshape according to the according to your choice, and then fix them up with these sonic pins. And they give a relatively good fixation, though it's not as strong as the titanium plates and screws. It is good enough. So, of course, you could still do this with thread, or we could do with steel wires and pins. But then, post-operatively, 6 months or 10 months, 1 year down the line, there is no residue of the plate. The patient has a better cosmetic results with these absorbable plates. You see, you dip the absorbable plates into the warm water bath, and then you reshape them using you have put them into the orbital bandio and fix the orbital bandio in the shape you. So you could also use titanium mini plates and screws, especially where it is not visible. Generally, for the frontoorbital bandio, or wherever it is visible to the external visible, I prefer to use the absorbable plates and screws. But where it's hidden by the hair, then you can still use the titanium screws and plates and fix it. So what is new is the distractors. So the distractors are a set of instruments. Basically, what it has done is, previously, because of the increasing blood loss, we used to stage the surgeries, or we used to ask the patient to come back after some time till the patient is in a state to withstand the blood loss which is expected. So what distractors have done is, distractors have taken away this problem, and they have minimized the blood loss and given outcomes which are as good as more extensive surgeries. So, and also you can decrease the age at which you are operating the patient. So especially in patients who have increased intracranial pressure or airway compromise, who have severe extraorbitism, who have severe Chiari malformations. So in all these patients, you can actually perform the surgery much earlier than what we used to do, and with much less blood loss. So the entire principle of distraction osteogenesis is based on the fact that you are going to make a proper free flap, and you're going to fix it to the bone which is not a free, have a distractor connected to an external which protrudes out. So over a period of 3 to 6 months, you slowly distract the bone so that the flap which is being mobilized. So for example, this flap which is completely free 360 degrees from the rest of the skull is distracted over a period of time. So you get reasonable immediate results because you have done a bit of distraction, and over a period of time, you can actually increase the distraction to as much as you need. Of course, it is a little uncomfortable for the patient because of this jutting, of these bias jutting out, but then it gives you very good results at the end of 6 months. So there are again different types of distractors. You have different distractors for the scalp. You have different distractors for the maxilla. You have different distractors for the mandible. So depending on what you want, you use the either this retractors or this red retractors from all these red retractors which can be used. So the entire principle is the same. You make a free bone which is not connected to the rest of the bone. You put multiple screws on that, put it onto a stable bone, and then distract the bone depending upon the result you want to achieve. So over a period of time, this gets corrected. And you can also do it in a unidimensional, you can do it bidirectional, or you can do it multidirectional. So this is the great advantage of retractors. And one of the other disadvantages of an open procedure is that sometimes you do not get good cosmetic results. Sometimes you get an asymmetry. So this sort of asymmetry, by doing multiple distractions at different vectors, you are able to attain a better cosmetic result over a long period of time. Of course, there are failures in infections, skin extrusion, skin infections, device failures, migrations, the thing popping off, the child poking himself. All these are very important. These have to be explained to the patient, and you need a high degree of reliability from the parents of the child, and they should be able to take care of the child. We have had distractors which are put and they're broken and come back. So all these things are part and parcel of this treatment. But if they're well informed and motivated to carry out this distraction, it's quite a good option. So like I said, you do an osteotomy, you give a latency period, then you do a distraction, then you wait for the bone to mineralize, and then you remove the retractor. And this is the advantage. There's no need for grafts. The soft tissue is also distracted. The distance of the distraction can be reproduced, and also it can do it in multiple vectors. There are some other things which I have personally not used cranial springs for sagittal craniosynostosis, but they are used. Basically, all the whole thing is these can be done in much younger children. Endoscopic suturectomy we have done in a few cases. The endoscopic suturectomy is basically done in very small children, less than 2 to 3 months of age, in which you can actually just do a small endoscopic incision. Basically, it's a suturectomy done endoscopically. We introduce the endoscope, we make a small incision, and depending upon the direction of where we're doing the bone cuts, we do the bone cuts, just nibble of the bone. It's basically something like a open suturectomy, but this is done endoscopically. This again minimizes the blood loss, but the one condition for this is that the bone has to be very soft, which can be achieved only in younger patients of less than 2 to 3 months. Of course, for the lazy lambdoid, for the posterior plagiocephaly, helmet therapy is being used. It starts within both. It can be done as a prophylactic to, especially with children with this lazy lambdoid, or that to prevent formation of head shape. And post-operatively, lots of surgeons used a helmet to maintain the shape and allow the head to grow depending on the shape they want. So these are the various types of helmets, and these are used both when the patient is not being operated, when you want to prevent the child from developing deformities, or post-operatively when you want when you want to maintain the head shape and you want the head shape to grow in the desired direction. So I think I'll end here. Thank you, and thank you, Dr. Shukla, and all the faculty of our department for this wonderful meeting. Thank you.
Thank you, Dr. Dwarkanath. Actually, we are grateful to Dwarkanath. Like the resection of craniosynostosis surgery was done by Dr. Dwarkanath, because there was gap of 1 or 2 years, and Dr. Mohanty went to US, and it came to standstill. Then he restarted and we continued. So he has shown you all the tools. Now you are very well equipped. You know how to evaluate, what to use. Now armamentarium is ready. Now we go with strike for the strike. So we'll start with surgical procedures. So first surgical procedure is what we commonly done is anterior procedures. So for anterior procedures, we have Dr. Naresh Biyani, who will be giving the talk remotely. Dr. Naresh Biyani is pediatric neurosurgeon, and he practices mainly in BJ Wadia Children's Hospital in Mumbai, which is a very high volume children, one of the early children hospitals in the country. And he does quite a good number of surgeries for craniosynostosis in practice as well as in Wadia Hospital. So Dr. Biani will be giving talk online on anterior cranial procedures for craniosynostosis. Then we'll have a break, tea break. Then we'll start with posterior procedures and then midface procedures and so on. So I welcome Dr. Biani. Video on करो. उधर क्यों नहीं आ रहा है? Hi, Naresh. So we are just setting up our computer on the main screen in the hall.
Sir, you will have to unmute yourself.
You have to unmute, Naresh. You have to unmute yourself. Just need to unmute. Just to unmute. share screen बंद करना पड़ेगा. Control my settings. Naresh, can you speak something? Okay, he is not able to speak. I have to unmute you.
They are coming. Sir, that is calling.
Hello? That's what we are trying to do that. It's not happening. Wait a minute. ये बंद करो सिट्रिक्स कहाँ है डेस्कटॉप ओपन हो गया नहीं ना इसमें जब स्क्रीन शेयर आता है ना डुप्लीकेट स्क्रीन कर सकते हैं क्या कैसे करना पानी शेयर करो ना ये इसको बंद हो गया सिट्रिक्स ओपन है यूजर बाय डिफॉल्ट हेलो participants na Naresh Biani asked to unmute. It is showing asked to unmute.
No, now it's unmuted.
Unmuted. Okay, fine, good. So Naresh, can you speak something?
Yeah.
Yeah, everybody is able to hear, right?
Yes.
So
yes.
Naresh, thank you for joining us remotely. So I gave a brief introduction. I think you did not hear. Naresh is a
No, in the meantime, in the meantime, you can ask to slide share. I'll load the thing on the thing. You have to allow slide share the screen also, if you can, please.
He can do.
You can do now.
Yeah. You can do it in background now.
Can you share your presentation now?
Yeah. Just a minute. Yeah, you can introduce.
Okay.
Sorry.
So I'll introduce once again. Dr. Naresh Biani is a neurosurgeon who practices in Mumbai. And he's also attached to Bijaywadia Children's Hospital, where he does most of the pediatric neurosurgical procedures. And he is one of the lead surgeons in Mumbai who does craniosynostosis surgery. So we are thankful to Dr. Biani who agreed to join remotely. So Naresh, can you start your presentation?
Yeah. Thank you very much. Actually, I just want to add few things. I've been practicing exclusive pediatric neurosurgery now for past 17 years. And what
Great.
I'm going to talk today is the evolution that has come in my practice as well. I have been enjoying the morning session very well. All the basics and anatomy and the tricks of the trade that Dwarkanath was just showing. Craniosynostosis is uncommon disease and is premature fusion of cranial sutures. The indication of surgery is only two. It is cosmetic and raise ICT. So if it's a unilateral synostosis, it's always cosmetic. They don't get into raise ICT. At late stages, SCAFO has shown to have that. Raise ICT in multisutural synostosis. Okay. So frontoorbital advancement that I'm going to talk today, it's mainly for the metopic, unicoronal or bicoronal because it's an anterior deformity. And advancement also helps in increasing the intracranial compartmental space, thereby decreasing the raised intracranial pressure. Okay. Now, the surgery, the most important thing is the ability of the baby to tolerate the blood loss. Okay. In my hand, still it is around 50 ml, 150 ml minimum for a craniosynostosis surgery. And the child has ability to handle their blood loss stably by around, say, 20 ml per kg body weight, So I would operate electively at 8 kilos of weight, unless there is a raised ICT or other issues that would require an early surgery. Another very important point that Dwarkanath had just laid is that the periosteum and the durameter is very, very osteogenic. And its osteogenicity decreases after 12 months. So we need to use the osteogenetic property of periosteum and pericranium. And we do the surgery by around 10 months. So we have at least 3 months windows, where the bony islands that we keep can fill up. Okay. What are the risks of surgery? The main risk is hypovolemia and hypothermia, So these are the tricks that we need to do. Unlike other adult neurosurgical problem, the problem is that the surgeon and also the anesthetist, who are not doing this heavy volume work, they underestimate that. And by the time the child crashes, by the time the thing happens, you have already lost the whole thing. Blood needs to be started at the skin incision. What happens is that we start the skin incision and then try to call the blood. It comes, it warms, and then start. It is not like that. Scalp infiltration is very, very important. Adequate peripheral line, central line, or arterial line as per the comfort of anesthetist. Urinary catheter is there to monitor the blood flow, urine output. So I'll touch upon 3 techniques that I have been doing, and this is now my bread and butter actually, So metopic synostosis. Okay, so this is how the child looks. Most of them, they have hypotaylorism also. So we need to correct that as well. Okay, during the surgery. Now the important step is that I'll show you, from the lateral point of view, we'll see, the head has to be above the heart level. Okay, the tube has to be adequately supported. All the 4 limbs are wrapped into the cotton gamges. Okay, now this is the anti-gravity method that we use so that the child doesn't skid, Most of the time when the child skids, then it is a problem. And then we have 1 or 2 pillows so that the leg also is above the heart level. Okay, so we have 2 good peripheral lines in the leg and the blood can easily be given. Okay, once this is done, what I use is a L connector. You see this L connector. This would prevent the drapes falling on the chest and the baby, and then respiratory efforts are decreased. Okay. Here I don't have a picture, but then the blood transfusion also started before we start draping the patient also. Okay. So this is now the waterproofing that has been done to the child by using a simple sturdy drape. So the whole child is covered and is made waterproof. What happens is that with air condition on, the wet drapes can cause severe hypothermia, unrealized to the patient, surgeon as well. The surgeon would be busy operating. So this is a standard protocol that we follow. Okay, this is how the child looks at. So only the surgical part that is needed, and the tube, is in the vision, for the anesthetist. Okay, now the skin incision is marked. Most of the time it is curvilinear incision, zigzag, at the biparietal eminence, so that we get whole of the pericardium. I drape myself. So once the draping is done, the cleaning and draping is done. So this is how the drape is put under the head. This is a sandwich where there's a plastic sheet in between the two drapes. So that is kept. So again, the child doesn't get wet. The main purpose of all this procedure is that the child doesn't become wet and hypothermia is prevented. Okay. And then the complete draping is done. Okay. I use a lot of this betadine. Just my boss used to use it and I'm still continuing that. Okay. The whole pericardium is exposed. Here we have used rainy clips to decrease the blood flow. Sometimes, or dandy can also be used. The blood loss can be quite significant unless it has been done. What I have also done is I have put a gauze piece in between the skin, so that it is less traumatic to the body. Okay. This is how the pericardium is all exposed. Now the marking is done. I don't cut, I don't do osteotomy straight, I would harvest the pericardium, and the pericardium has to be vascularized. The arrow shows that where is the vascular pedicle coming in. Once that is harvested, now the bone flap is seen, the bone is bare. If it is multisutural synostosis, they would ooze like mad, So you need to have a warm bone wax ready, maybe 2 or 3 of them, and continuously the bone wax needs to be applied. And if it is kept dry, then it seals off by itself as well, Here we can see, the signs of raised ICT also. Now the metopic synostosis should not have that, but here we are seeing that, the very thinned out bone. Okay, this is how the pericardium flap looks like. Now the marking is done, and that is the trick, So now this is A, B, C. And when we see, it is decreasing in the size. So we use this malleable plate to have the forehead. Okay. So this is the biparietal bone that we are going to harvest posterior to the coronal suture. And this would look like this, So this was advancement we are going to get in the metope. So once we know this, the whole craniotomies are done. The orbit is also separated from the frontoorbital bandu for the bandu. And we make sure that pericardium's periorbita is not damaged, Okay. So these are the marking. And we make sure that we have enough base at the temporal region where our whole bone flap is going to be anchored. Okay. So now this is taken out. And you can see the difference, the metopic, this is a bifrontal and this is the bicranial, Okay. And these are from the inside. And what I forgot the name of the radiologist, what she was showing, the M sign, So we have to be very, very careful because you can have emissary veins that directly coming from the sagittal sinus, going through the bones and then entering into when the bone flap is taken out. And for an untrained person, you can have a massive bleeding, number one, and air embolism also, So one has to be very, very careful in this step when we are taking it out, And preoperatively, seeing the images would help. Once the bone flap is taken out, the workstation is changed. There is another trolley where the bone work would be done. And the whole skull is covered with wet mops. Okay. So on the workstation, the bone work is being done. Okay. I do with my plastic surgeon. So there are 4 hands working together. And then there is a person who would keep on putting the drill also in irrigation as well, So once the new forehead has been made, this is from the inside, Over past maybe more than 15 years, we have been using PDS, I haven't used absorber plates or metal things. PDS, 1 number PDS is one of the very strongest thing. You have multiple way. And since this is a metopic, we need to have the supraorbital margin also that has been apart. So this from inside. And this is how the thing looks outside, So what we do is that all our knots are inside, So no knots is outside. Okay. So now this is the lateral cut that has been made. and where the anchor would be done. And again, here also we use the PDS. This is the line that you see is the lateral margin of the, sorry. Yeah, this line is where the lateral margin of our forehead would be anchored, you know. Okay, this is after the main bone flap is fixed, morcellation of the remaining bones are done. And this, for this I use 2-0 PDS. It should be not very tight, but be sufficiently tight so that it is in touch with the pericranium, you know. So the pericranium would have a osteogenicity and can form the bone. And once it is in touch, you know, the more and more callus formation happens. You know, we don't want it to be floating. If it is floating, then it doesn't unite. Okay, this is how it looks from the side, you know. We do the radial cuts posteriorly also, but in this case it was not needed, so it was not done. And after that, the pericranium cover is placed. And once the pericranium cover is placed, we close the sutures. Okay, I use staplers. These are hemostatic and is very pretty fast, you know. It saves our time. And after the surgery, you know, we can see, you know, there is a frontoorbital advancement, and then there is a bump also, you know. Its shape is very nice now, and you can see the bump, you know. So we always try to overcorrect the metopic synostosis. Since it is a genetic abnormality, everything that we do, it undercuts, you know, it corrects over time, you know. So we have to tell this to the family beforehand as well. Okay. So frontal orbital advancement for bicornal synostosis. Here is the child with severe raised ICT and bicornal synostosis. Okay, this is how the child looks like. This is operated at around 14 months. They came to us late. Okay. Lot of people would do minimum head shaving also, depending on the patient preferences. Otherwise, complete head shave is done. Same bicornal incision is taken. The bone flap is exposed. Okay. Now again, we take the forehead, you know. So now the A you are seeing, right? So that would be the base for the new forehead. Okay. And this much advancement would be done, you know. You can see that thing, you know. So now in metopic, what happens is that the midpoint is already stable, you know. But in bicoronal, you know, because there is already an anterior cranial fossa that is shallow, we need to have a support. Okay. So this is how it would look like. Okay, so now the lateral markings are done. And then from the posteriorly, a wedge type of a bone is harvested. And now a new forehead is being made. Okay, so all the knots are within, you know. So the child would not feel any knot under the subcute. And this is the wedge type of a thing that is there. And then the child had a severe raised ICT as well. So it needs a good advancement. Okay. And this is the lateral canthus sutures that we has taken. So that the orbits are also fixed appropriately. And here is at the end of the fixation, you know, with the PDS, this is a very stable fixation. It is done. The pericranium flaps are replaced back. And then the staples, skin is closed with the staples. Again, after the end of the surgery, the frontoorbital advancement should be enough, you know. So it should be visibly seen, you know. Third one, for unicoronal synostosis. Now, there are people who do bicoronal, bifrontal craniotomy, but since it is a unique sutural pathology, I restrict to the same side. Okay, the whole skull is exposed. Now, this A is marked, and this is going to be the new forehead, you know. And how this A is marked is, so that is the side to side, you know, from medial to lateral. This is the curve that we want. And that curve should be matching with the base of the A. Okay. And this is the anterior posterior curve. And that needs to be with the shape of the thing. So with practice, we know, you know, that this would be the new forehead that can be easily harvested. So this is how it is reconstructed. And then the orbital roof is attached. Okay, and this is how the thing is fixed after the thing. There should be an overlap, So we would cross the midline and make the burrows so that there's a rigid fixation. And after the surgery, there should be a visible bulge at the lateral part of the orbit, and the rest of the bones are morcellated and are fixed with 2-0 PDS. Okay, and after the whole thing is done, pericardium flap is replaced by. Sometimes you can have a very big dead space over here that can be filled with gel foam, and then the matter gets absorbed, and it also helps in the healing. And this is the shape immediately after the surgery. Okay, so what are the take-home messages? Important to recognize early. CT scan is very important for the diagnosis. Now we are also doing more and more black bone MRI. The problem is that when the child presents to a neurosurgeon, the pediatrician or the referring doctor would have already done a scan, So that needs to be aware, make more aware. Surgical results in appropriate treated children are excellent. Important step during the surgery is hypovolemia, hypothermia, and this is what is the mainstay for any pediatric cases. But for craniosynostosis is much important. Speed of the surgery, it's a teamwork. A single neurosurgeon trying to do it would take at least 3 hours, 4 hours. But with a plastic surgeon or a colleague, the things become very fast. Quick in, quick out. That is the moral of the story. Okay, and can be safely done. The things that have changed in my 17 years of practice is that I try to do for a single social stenosis as late as possible, because this is a genetic abnormality. And I have seen people doing at 3 months, 6 months, and by the time the child is at 12 months, 18 months, everything gets undone, Now, the people who would try to publish their result is that they would have taken a genetically or phenotypically, there is a phenotypic expression and genotypic expression. So we don't know how severe is the genotypic expression that is going to happen. And the earlier you do in a child who has a very severe genotypic expression, everything gets undone, And this is one of the reasons why the suturectomy also doesn't help, If we see the evolution of the surgery also, at the Necker group, that is how they evolved, and they were the first pioneer to do the whole vault expansion. So its main important thing is the genetic expression, and we don't know, how much is going to be the severity of the expression. Second is that I have not been using any absorber plate. When I started my practice, absorber plate was well in demand. But with this technique, that I showed now, we don't need an absorber plate. We have a PDS that is a very strong material, and it gets absorbed in 1 year time. And by that time, the rigid fusion happens. And another thing is it's expensive as well. And I have never used metal hardware. One of my mentors, he never liked the plastic surgeon, Dr. Nitin Mokal, and we never use the metal hardware. Yes, if somebody uses it, chances of migration and foreign body reaction, maybe the nidus and fever, means osteomyelitis, lot of things can happen. So better not to use that. Okay, and better awareness among the families. Previously, we used to find it very difficult to convince the family that the surgery would make a difference. But with the internet and more people doing safely the craniosynostosis surgery, the awareness is improving among the doctors, among the neurosurgeon, among the families. It makes a help. And then we have a very nice craniofacial support group, what the Dhaval was explaining in his talk, where when I see the patient for the first time, we connect them to this craniofacial support group, and the family can really see the examples in live, like somebody had got a surgery done 1 year back, 7 years back, 10 years back, and they know, what would be the result and how is the result going to be expected. Most of the problem that people feel is that the craniosynostosis is untreated, they will be mentally challenged, and this doesn't happen, Craniosynostosis, this is the disease of the suture, unless it is syndromic or multisutural, they have a very good outcome. Mentors, Dev Pujari sir and Dr. Udayanda sir, and the plastic surgeon who has always been a big support is Dr. Nitin Makul sir. Thank you very much.
Thank you, Dr. Biane. That was really a very good talk. Like Dr. Biane covered entire procedures for three common scenario, metopic synostosis, bicoronal and unicoronal. So each requires tailored amount of bone resection, tailored amount of advancement. I hope you all have understood it very well. He explained very clearly, step by step. So thank you, Naresh. That was really very nice of you to give talk remotely. So we are going to have now a tea break for now. And before that, I request all the participants to come and gather in the center of the hall so that we can have a group photograph. So all the people who are sitting in the periphery of the hall, please come to the center of the hall. Naresh, we will Photoshop you and add you in one of the empty chairs.
nahi, chalta hai. See, the knowledge has to go in, that is more important.
Yeah, no, that was really good because I have attended his talks earlier. So that is one good. Like, and one more thing, message. Please, by the time I keep on talking, all of you come to the center of the hall. So one thing, like we also avoid any of the implants materials as much as possible. So
Correct.
like I and Subhash, what we call it Sui Dhaga method of suturing the bone.
Correct.
So that works very well, and that we also have been doing for quite a few years. But yes, we are not like rigid that we don't use bone, we don't use metal, or we exclusively use. We use combination of techniques. In a given child, also, some part maybe with absorbable plate, some part with Sui Dhaga, and some part with metal in older child particularly. Thank you, Naresh. So I think all of you, please, whomsoever is, come in the front chairs also. Otherwise, you will be out of focus. So as much possible, like bell's curve, it will please be in the center of the hall. Naresh, I am also going to sit there. So
Yeah. Thank you. Thank
bye
you.
bye.
If there is any question, somebody wants to, I don't know, you
Any
have
questions are there for
some
Naresh?
group or something, I'm happy to answer them,
So we are going to have question answer session later. So if there are any particular questions, we will call you and then you can reappear.
Yeah, that's okay. I would be in the surgery from 2 o'clock actually. So just let me know. There's
Fine,
no
fine.
problem. Suhas is my guru bhai, and my technique and his technique is not very different actually.
Okay, bye. I'll go and sit then in one of the chairs.
Thank you.
यार अगर focus करो। you.
1 second.
कंट्रोल P है ना, उसको डुप्लीकेट करना है, डुप्लीकेट है। आ गया
इधर आ रहा है पर हमें ये करना पड़ेगा ना।
इधर पता नहीं चला 5 साल हो गए कोविड आया, तो फिर भी हम इतना स्ट्रगल कर रहे हैं।
अभिषेक स्क्रीन जो है ना,
शायद पोपट
पावर पॉइंट मत दो, मुझे स्क्रीन देनी।
पावर पॉइंट देना है सर।
राइट।
ओके,
बाकी के बंद कर दो। Okay. So welcome back. So we move further from front to back. So we have already seen the anterior procedures for craniosynostosis surgery. Now it's time to go back and see the posterior cranial wall procedure. So for this, we have Dr. Suhas Uday Kumaran. He's a neurosurgeon and now he is exclusively pediatric neurosurgeon. And he runs a pediatric neurosurgery program at Amrita Institute in Kochi and the program director of pediatric neurosurgery program. And I think a couple of our alumni also have done fellowship under him. And he does a wide range of pediatric neurosurgical procedures, among which craniosynostosis is the leading one. He has a very good team along with a maxillofacial surgeon. So in Amrita, they operate quite a lot of complex and multisutural craniosynostosis, particularly craniofacial surgeries. So I invite Dr. Suhas to give a talk on posterior cranial wall procedures for craniosynostosis. Dr. Suhas, please.
Good morning, everybody. Thank you, Dr. Dhaval. Thank you, Dr. Subhash. Thank you, the Nemans team. Thank you, Dr. Dwarka, for inviting me. As you saw, the last session was on frontoorbital advancement, which is classically for non-syndromic or mostly at a later stage of syndromic ones. Posterior calvareal vault is a primary workhorse of mostly the syndromic ones, especially one which have multisutural involvement, one which have posterior calvareal involvement, and occasionally for non-syndromic, like extreme brachycephaly, and sometimes for secondary craniosynostosis. So what do you want to address in posterior calvarium? The primary goals are you want to decompress the posterior calvarium to increase the posterior calvarial vault volume. You want to decompress the posterior fossa. You want to increase the anteroposterior calvarial width. This is in classical brachycephaly. You want to reduce the flattening of the posterior vault, especially when you have lambdoid synostosis. When it comes to craniosynostosis, the classical indications are: one, when you have an extreme raised ICP in multisutural synostosis; lambdoid synostosis, a classical indication, either unilateral, non-syndromic, or syndromic. Wherever lambdoid synostosis is involved, posterior calvarial vault distraction or posterior calvarial vault is addressed separately. Extreme brachycephaly, posterior calvarial vault distraction, or any kind of posterior calvarial vault addressal is an indication. Chiari malformation, which is mostly of the complex varieties, are addressed by addressing the calvarial vault. Primary simple cranial Chiari is not as a part of this. And any situations where you have a raised ICP, acute or chronic, non-specific, you can use posterior calvarial vault as a solution when you don't want to disturb the anterior calvarium or change the aesthetics of any child with a non-specific raised ICP. And sometimes it's used for extreme positional flattening of the back when we are not able to correct by conventional conservative means. And then in secondary craniosynostosis, like the craniocerebral disproportion, secondary to extreme shunt-related malformations in prematurity. So classical craniosynostosis varieties which are indicated are multisutural, lambdoid, brachioturocephaly, and secondary craniosynostosis. So how do we address the posterior calvarium? The classical options are posterior calvarial advancement or augmentation. You do not do the classical kind of release surgeries in posterior calvarium because the relapse is very high, because of any patient, any child lies on the back, hence the relapse is very high. So classical release, which is done elsewhere, wouldn't be possible in posterior calvarium. So advancement or augmentation, meaning you need to fix it. Then you have the posterior calvarial distraction, and morcellation and release might be used as a very early means and neonatal or plus period, so that you want to save the situation beyond a situation where a larger surgery, including distraction, cannot be done. So this is a classical algorithm and not very rigid kind of algorithm, but I want you to look at where a posterior calvarial vault distraction is or posterior calvarial vault is addressed. So we look at signs of raised ICP, airway, aesthetic issues, or other functional issues. But where in situations where ICP is raised along with presence of Chiari and hydrocephalus, and of course aesthetics is involved, you select posterior calvarial vault distraction. And this is ascertained by use of MDCT, MRI to pick up hydrocephalus and the Chiari, and sleep study to look for central apneas. So apart from the classical CT signs, which our colleague from radiology and Dr. Dhaval and my other colleagues mentioned, certain signs which are very subtle, but classical indicators are possible direction towards a use of posterior vault surgery is presence of hydrocephalus, presence of Chiari, presence of, lack of subarachnoid space, which would indicate raised ICP, the enlarged emissary veins, and sometimes in treatment follow-ups. So you have a Chiari, you have lack of subarachnoid space, you have large veins, and a tight posterior fossa. Just some other background information on when posterior vault distraction or posterior vault surgeries are done is one is hydrocephalus. These usually go together and directly lead to posterior vault surgeries. So hydrocephalus is very common in syndromic. Every one in 8 patients of syndromic would have hydrocephalus, and Chiari malformation is present in about 90% with syndromic craniosynostosis, especially if lambdoids are involved. But Chiari malformation by itself is not sufficient for the onset of hydrocephalus, and Chiari cannot be considered as a simple result of chronic intracranial hypertension induced by hydrocephalus. So, although both can be present simultaneously, both may not go together, but at the same time, Chiari and hydrocephalus as entities are direct indicators of posterior vault involvement. And the same certain things which need to be remembered or are different in craniosynostosis is a progressive hydrocephalus can be present without ventriculomegaly. That's very important to understand, because you say that there's no ventriculomegaly, there's no hydrocephalus, which is untrue when there is a severe raised ICP and craniosynostosis not allowing the ventricles to dilate. So when you have hydrocephalus per se might elevate that pressure, whereas any kind of there are secondary effects which are happening, which adds to hydrocephalus. And the pathogenesis of hydrocephalus in craniosynostosis is different. There's crowding of posterior fossa and venous hypertension. So that's why the posterior vault addressal comes into a direct role. And then, of course, it can relate to coincidental other causes. And then Chiari is another accompaniment for this direction of strategy. Because there's a cranial base deformation, jugular venous stenosis, and associated cerebral herniation with a rapid neural growth happening in the infancy, venous hypertension, and secondary outflow resistance. So if you look at these entities, they are very complex in terms of evolution. When it comes to hydrocephalus, ETV or VP shunt, controlled VP shunt are possible, but posterior calvarial vault addressing the posterior calvarial vault is a direct physiological or functional answer. So when it comes to hydrocephalus and Chiari, any of these patients who have hydrocephalus or KRE require a total calvaryal vault reconstruction, either staged or in a single step. So what are the classical ways which posterior calvaryal vault is addressed? Classically, there are at least the conventional remodeling, which has been used always since ages. And then in recent times, let's say in last few decades, we have the distraction and spring-assisted expansions. Essentially, what needs to be understood is distraction allows the maximum volume gain versus the conventional and the spring, which would allow moderate to high. Complications are probably less in distraction. I'll come to the details as I go through the presentation. And in conventional remodeling, probably in the complications are higher. This is just an outline. We'll go into the details as we go into the next slides beyond this. So PCVD, or posterior calvaryal vault distraction, is used as first procedure in syndromic. That's our protocol. Most literature again prefer the same because because of the presence of raised ICP in syndromic ones, hydrocephalus and lambdoid involvement, and central apnea. And at the same time, you have a situation which is addressed by less of morbidity, quicker procedure with a greater functional benefit. The classical indications of PCVD, as I mentioned, ICP, craniocerebral disproportion, pansynostosis, lambdoid, and tetracephalic. This is an illustrative situation. A 9-month-old cruisen with the classical signs of cruisen, with MRI showing low-lying tonsil and probably an incipient hydrocephalus. So that's on you have the classical signs, classical findings. So here we chose posterior calvaryal vault distraction as is a protocol in most units who perform craniofacial surgery. So you can see the flattening of the lambdoid, sutural involvement of the lambdoid, bilateral sutural involvement, coronal sutures are well preserved, bilateral sutural involvement with the lichen channel appearance. And that's the posterior calvaryal vault distraction happening. I'll go through the details of the procedure. I just want you to know the principles at this stage, and then later we'll go into the details through a video. So those are the distractors. These ones are called KLS through KLS Martin, which have their foot plates which go into the edges of the bone, and as we distract, the edges move backwards, allowing the posterior vault to create more volume. And this is a supratorcular, where the lower cuts, the inferior cuts, are above the torcular. We'll go through the details as we go in the video. That's after distraction. You can see the flattened portion has been pushed backwards, with the distractor still in place, which is kept for a limited period, which I'll mention later again. So this, he again went on to have a midface, but that's not about the. So this here you can see the supratorcular cut. This is probably the large emissary vein. We go above it again to for the sake of preserving the vein and for the sake of allowing safety. And one of the facts is supratorcular or subtorcular may not increase, may not have difference in terms of volume gain. So this is the distraction. After it has happened, you can see the new bone formation already happening, bridging bones at about, let's say, around 6 weeks to 3 months. So you can see the difference, the flattened lambdoid and the involved lambdoid with change of posterior calvaryal volume. These are one of the initial cases. So technically we were on our premature situations. So again, supratorcular. So this is a craniocerebral disproportion secondary to extreme prematurity and early shunting. So you can see the flattening and extreme short anteroposterior distance. So you can see the difference after the posterior calvaryal vault distraction. This is pre, this is post. So this is used as an aesthetic procedure in children who are doing well in spite of their craniocerebral disproportion and their past prematurity. So you don't do it in children who are extremely damaged or who are not doing well. You don't allow this morbid kind of surgeries for no benefit of this. So just to tell you some distraction principles, the classical principle has come through the Ilizarov technique from the orthopedics. You have seen these techniques in your MBBS days. You use it for limb lengthening wherever persistent infection is there. Classical Ilizarov technique. And from there onwards, it was taken to maxillofacial by Joseph McCarthy for first use in mandible. And this is probably one of the first experimental animals where the extraction was used. And he thought that use on membranous bones are much better than the limb bones, which earlier Elizabeth technique was advocated for. So just to let you know what happens during this traction, this is the classical fracture sequence at various days, initial inflammatory response. And then similarly, after surgery, we have the change of endochondral formation and bone formation and remodeling over days. Between 7 to 31 days, you have a new bone which starts remodeling in the same fashion as a classical fracture. What are the advantages of having distraction? Distractions, it is done on a classically surgical cut bone, so has a good bone supply, and it's never detached from dura. Hence, it's very valuable in calvarium. There is no extra dural dead space that is produced. So hence, there's no additional collection. So probably a lesser chance of infection. Soft tissue is very gradually distracted, and advancement allows more of distraction, more of space to be gained, more of the bone gap or volume to be attained because it's a slow distraction. So hence, since a new bone is formed, there's no bone grafting that's required. It's less invasive. It has shorter operating time, less blood loss, so that can be used more than the conventional procedures in the youngest ones of in infancy. Disadvantages, you need to understand the physics of it. So you have to have, need to understand the proper vectors of destruction. It can be a port of infection, like any kind of pin site infection, or sometimes deeper. I had a patient who went on to develop a subdural lymphoma. Sometimes you have implant failures if you reuse these implants because they're extremely sophisticated, fine instruments. Then sometimes when the lambdoids are open, a phenomenon called gullwinging happens, where the lambdoid breaks as the distraction happens. So multiple disadvantages, but overall it's a very advantageous and a phenomenal legacy in the craniofacial armamentarium. So these are the modified rates of distraction. The youngest ones, we are very fast. In the oldest ones, probably much slower because you expect the bone to grow less in a slower rate. So youngest ones, if you realize, even in frontoorbital advancement, we don't distract. In the infancy, we don't distract. We distract in posterior wall distraction because we want to gain maximum volume. So you can move fast, but still have the advantage of distraction by allowing the soft tissue to expand along with. Not the calvareal gap is not an issue in the youngest ones. In older ones, the relapse is higher if you keep the calvareal gap. So distraction is more beneficial than probably the younger population. So older the child, distraction becomes mandatory to get extreme kind of appropriate results. So these are the different vectors that are used. Classical brachycephaly might have only a posterior vector. Tury brachycephaly requires postero-inferior vector. Craniocerebral disproportion requires bilateral uniform posterior vectors. If you have single side lambdoid, you require asymmetric expansion. And suppose if you have Chiari where you use distraction, then it's again posterior-inferior. Again, and latency period depends on the age of the child as the growth potential changes. So over time, older children require a larger latency. And these are not strict rules, but the principles needs to be understood. We have been doing this PCVD since a decade plus. So we have been rethinking on how a PCVD is truly a neuroscientific procedure. So we have been thinking in terms of the weighing, the volume, and the aesthetics, and how we can deliver better outcome in these children. So, if you look at the large veins, the PCVD is a very good procedure to decompress the posterior. But what we additionally do is we decompress the whole vein across until all the larger veins of the posterior calvarium, including the tocula and that sigmoid till the base of it. This gives us the advantage that we don't touch the tocula. We allow the tocula to remain, but at the same time decompress the vein elsewhere to be more safer. And as the bone moves backwards, we allow the dura to contour the posterior calvarium so that there's no step deformity, and probably increase the volume at this level. Additionally, we barrel stave so that the site of sinus is again decompressed. So we address the vein primarily along with the calvareal bone. Additionally, a tailored vector is done. This is a classical posterior vector, and this is a posterior inferior vector when you have tuberosity. Again, to deliver a better aesthetics. Volume, the KLS Martin or most of the distractors allow at least 2 to 2.5 centimeters of translational vector, hence giving us the maximum volume change. So along with this craniectomy, the volume secondary to the distraction, the barrel staves, we achieve maximal volume. So we have started working differently when it comes to a classical PCVD. So here you can see a tuberosity, which is addressed, and this is a classical pansynostosis being addressed with the same principles. So, and next comes the posterior wall augmentation. You need to be aware of it because it's a classical technique when you do not have distractors with you, or the cost is prohibitive. So this is an article from Birmingham group, Girish Solanki and his group, where they have used it for Chiari, and you can see what they have done. They fixed it after moving the bone backwards and downwards with plates. So this is an additional older article by Professor Wagner at Mainz, where again, the most important problem of posterior calvareal augmentation or advancement is the relapse. Now this has been again fixed by a technique which they propose is useful. Again, you need to have all this in your armamentarium because you need to understand that all situations you cannot get a distractor in place. Now this is a spring cranioplasty where springs are used to distract according to whatever targets you want to achieve, either aesthetics or volume. Again, these are placed very critically or strategically to achieve the outcome which you specifically want to. Now here you can see the posterior inferior vector which the spring has attained. Springs in my system has an advantage that it is cheaper, and probably I don't need to go into a situation to remove the distractors back. And this we make from classical knitted dental wires, which my colleague has adequate. So this whenever a patient is not affording for distractors, we use this, but this gives us a lesser amount of translation, about 1.5 centimeters compared to the 2.5 centimeters, which a classical posterior calvareal wall distraction allows. We slightly modify our posterior calvareal wall distraction to a technique called as PCVD plus, where we add other techniques immediately while the posterior calvareal wall distractors are removed. Now, this concept is for the addressing the fact that the maximum cognitive development occurs in first 5 years of life, and all the factors which affect the cognitive development or functional development of any child should be addressed less than 5 years or much earlier, because we do understand that a classical development does not stop, does not happen beyond that. At least whatever we understand from the science of it. So in older children, more than 2 years, we go ahead with frontofacial first and use PCVD as backup, and the midface too, depending on their requirement. We use the robot because these kids have abnormal midface and very small midface and deformed midface. So for precision's sake, we add a robot to it. And PCVD is first line for the younger children. PCVD might be added to these children if they require any kind of raised ICP situations later in life, because we believe that to improve the psychology and appearance, this becomes a primary tenet after 2 years, and PCVD may be added up later. So that's what we call as comprehensive protocol. Now, this is an example of a posterior calvareal wall distraction in a classical tuberosity. You can see the first attempt with a PCVD, and then a FOIR has been added. And so this is what the final appearance of this classical tuberosity, an extreme one, but with this kind of outcome, you have a satisfactory picture. Now, this is again pansynostosis with PCVD, shunt, and then addressing the frontal. So we call this a comprehensive protocol, again, in less than 5 years. So that's an example of a classical comprehensive outcome being created by a complete 360-degree addressal of the calvarium, PCVD, midface, and frontal wherever necessary. And this is just one example of it, since the talk is only PCVD. I'll show you a video, probably a few minutes old, created by one of my junior colleagues from maxillofacial department, again PCBD, where you can get the all the principles in detail. The classical position, supine on a horseshoe, with all the standard precautions of any craniofacial surgery, hypothermia, all kinds of standard avoidance of blood loss, protection of the eyes. These eyes are very protuberant. You need to protect the eyes and the face and the calvarium. Now, this is a distractors being pre-planned after the first draping. So this is the skin incision. Again, classical is exact, but you need to identify the place where the distractors have to come out, because you don't want to have a situation where the distractors are coming out to the wound directly, or a ledge of skin in between, so that they get necrosed post-op, and you might have to abandon the distraction in between. So it's a very slow video for all the juniors you are here, so that you can accept. Most of the neurosurgery residents need to accept that this is a neuroscientific functional concept that needs to be got into your armamentarium as early as possible. Craniofacial surgeries are aesthetic on paper, but at the same time, they are highly functional when it comes to children of this age. Highly functional, and probably determine their long-term outcome along with the aesthetics. So that's the superior still dissection. Classical marking of the bone cuts. Classical marking of the bone cuts. So the vertex is preserved, and because you don't translate the maximum height, you translate the curvature, so that's how the marking is done. The lateral extreme lateral surface needs to be flat, because the distractors have to be placed in flat surface, so the vectors move in a very efficient way. This is the infra or supratrochlear marking, whichever you prefer. This is an older child. That's why the bone is so rigid and clean looking. In a child who is truly syndromic with all those lacunar bones, you might not have such a clean bone. So this is the distractors. You identifying the vector, which you have already pre-planned in your pre-planning. Now that's a distractor. That's either directly posterior or posterior inferior, depending on whatever you want to target. Now this is if you notice, it's probably a pansynostosis, an older child, and you can see the footplate of the Caelus Martin kind of distractor, well placed on a flat surface. And again, we're trying to gain the vector on the equivalent one on the opposite side by using probably some kind of parallax method to avoid misplacement of the directions. Essentially, you have to anticipate the terminal events in these vectors. So these are only thing is that these surgeries may not look very grand, but at the same time, a lot of small base of technical details are very important in terms of physics, in terms of neuroscience, in terms of course, the medical science. The sinus, again, like any classical syndromic children, we are very careful at the sinuses, central sinuses, the tocula. You have to be. And these I don't need to reaffirm here that all these surgeries are not just cut and go. They are extremely serious business. You have to be very strict about all these small techniques, which can at any moment lead to a different direction of surgery. So that's the infratrochlear cut. Cuts are made with all safety precautions in place. You use all kinds of technique which you have learned until that time to be as safe as possible. That's the infratrochlear portion coming out where I am trying to do a cranectomy. As we mentioned, we prefer the venous decompression along with the calvarial vault. So we don't. The bone loss is not an issue at that area, because bone catches up very fast in syndromic children, especially the youngest ones, where we work on. And these are the distractors being placed. the foot plate into place at the edges, identifying the place where the ports are supposed to come out. A well-planned one again. The incision was planned at the beginning, and the exit is planned at this stage. Through the period, a good thickness of tissue, the ports come out. Screws according to the thickness of the bolt, again pre-planned. Self-tapping. Again, the dura has to be protected. The dura can be thinned out. CSF leak is a complication at this stage, because a CSF leak can make you abandon the distraction in between. Foot plate modified. Sorry. This is an activator which is showing the distraction happening. So this is, you need to check on the table, because you need to be sure that all sides are completely cleared and free. Especially when you do minimal cuts, you might miss a ledge of bone, which might be a spicule or some kind of a bridge, and hence you need to check. We usually check on table, but bring it back to the edge with edge-to-edge position, because you want the edge-to-edge position to be is a part of the pathological catch-up. So there's a lock there, which allows which disallows reverse rotation, so that once an activation is done, once the movement happens, it does not go backwards on its direction. Again, zigzag with all incisions in place, avoidance of infection, all standard procedures. So to conclude, PCVD, posterior calvic vault surgeries and posterior calvic distraction is a highly functional concept, which a basic neuroscience concept, and this addresses syndromic and any kind of involvement of the posterior calvarium for all possibilities. Thank you.
Thank you, Suhas. That was really a very useful technique. Like both anterior and posterior procedures both have different purposes. And Dr. Suhas clearly mentioned that posterior is mainly for cranial volume expansion. And there are studies which have shown that as compared to frontoorbital advancement, posterior cranial vault expansion gives more volume gain in children with particularly pancranial synostosis and multisutural synostosis. Hence, there is a paradigm shift. Like traditionally, like a couple of decades back, you refer a child for craniosynostosis, standard frontoorbital advancements used to be done. But now we go from back to front, like you do posterior cranial procedure first, and then go for intercranial. And believe me, in non-syndromic cases like simple bicoronal synostosis, non-syndromic, you just do posterior cranial vault expansion, you may not even require frontoorbital advancement. So thank you, Suhas, once again. So now we have seen both anterior as well as posterior procedures, but there are some cases where you have to do whole cranial vault remodeling. In isolation, one procedure may not be sufficient, and particularly when the baby is grown up, it is feasible to do entire cranial vault remodeling. Literally, we'll take out the skull on the table and then remold and then put it back. So for this, I invite Dr. Arun Kumar. Hi, Arun, can you see me? So yes. Dr. Arun Kumar is an associate professor of neurosurgery at All India Institute of Medical Sciences, Bhubaneswar. He is an alumnus of NIMHANS and our own student. And he's one of the very few residents from NIMHANS who got trained here, who's got trained for craniosynostosis surgery and started craniosynostosis surgery program in his institute. So currently, Arun is doing quite a good amount of craniosynostosis surgery in AIIMS Bhubaneswar, along with maxillofacial and plastic surgeons. So he has established a very good program. So I invite Arun to give a talk on total cranial vault remodeling for craniosynostosis. Arun, over to you.
Thank you, sir. Am I audible, sir? My slides are visible?
Yeah.
Okay. Thanks a lot for the invitation, and I wanted to be present there for the meeting, but unfortunately, because of staff shortage, I was not getting leaves, and Dhaval sir had graciously agreed to allow me to present online. It's a great honor to present in front of my teachers, all my teachers. So I'm going to present, most of the things are already spoken about. Total cranial wall remodeling is basically a combination of all the techniques that we have seen till now, except probably the endoscopic technique. I will just, instead of going back again to the basics, I'll just go through some of the case scenarios where I had used total cranial wall remodeling as a modality for treatment. As we all know, craniosynostosis, clinical examination is the cornerstone for the diagnosis of craniosynostosis. The normal brain growth is the main force that propels the skull growth. Whenever there is abnormality in genetic abnormality and abnormal fusion of the suture lines, your brain growth is also affected, along with skull deformities. So there are various patterns. We all know about all these patterns. So usually the presentation is, other than cosmetic, there is raised intracranial pressure. The raised intracranial pressure can be because of skull base anomalies, tonsillar herniation, hydrocephalus, abnormal venous outflow. They can in turn cause airway obstruction, venous hypertension, as well as foraminal stenosis. So all these put together, the patients present with the various presentations that we have is mainly because of all the complex of symptomatology. So the patient can have respiratory problems because of poor development of upper airways. There can be visual impairment, hearing impairment, and there can be associated hydrocephalus as well as Chiari malformation, predominantly with lambdoid synostosis. So the timing and rationale is early surgery is important, as we have been discussing whole day. The 90% of your adult brain size happens within the first 6 years of life, and within the first 2 years, there is almost 70 to 80% of your brain growth happens. So any kind of restriction to this brain growth at this point of time is critical, and it needs to be addressed, and it will have long-term side effects if these things are not addressed. So, and the second thing is the osseous defects undergo reossification more completely around 1 year of age. The younger you operate, the defects close better. I will show you a few cases which is an example of this. Delayed surgery beyond 9 to 12 months of age leads to progressive deformity of skull base, as well as there will be effect on the normal facial growth also. Hence, the earlier we intervene, the better it is. So there are multiple ways to intervene. One is cranial wall reshaping. Other one is suturectomy, helmet therapy, and distraction devices. So basically, all these methods will help overcome the three-dimensional growth restriction, as well as it corrects the deformity. The advantage of cranial wall reshaping is you get an immediate correction, but it is an extensive surgery, more blood loss, and longer hospital stay is one of the issues. So, according to age, the more of the midface problems and the problems related to adjunct problems related to syndromic craniosynostosis are addressed a little later in the life, more than 4 to 5 years. Less than 4 years, you predominantly strip craniectomy, endoscopic procedures, and variations of pipe procedures, as well as total cranial wall remodeling come into effect. So I tend to, so mostly total cranial wall remodeling, as sir had mentioned, it is mostly used for cases which are presenting at a more delayed later stage with multiple sutural abnormalities. So I used to see all these multiple sutural abnormalities in relation to the basic shapes of the skull, like scaphocephali or dolichocephaly. So if you see this scaphocephali, usually we have multiple ways of doing whole cranial wall remodeling. I'll just skip on to this case scenario. So we have a girl presenting at 3 years of age with raised intracranial pressure, irritable and having failure to thrive. So this is the presentation: a dull, sad-looking kid with a long dolichocephalic head with some amount of ridging, as well as midface hypoplasia with parrot beaking. Kid has failure to thrive and was not performing well and having continuous headache. So the initial scan that was done, you can see the Dr. Sabha had initially mentioned about the Mercedes-Benz picture, where if you can see the pointer, let me just show the pointer. you can see the sagittal as well as bilateral lambdoid suture is fused, and there is some early fusion starting at the coronal suture as well. So this was the initial presentation, and the kid was it was around the around less than 1 year of age. They had got the CT scan, and after that the no intervention was done. It was neglected. And when kid presented to us, the kid presented with pan-sutural synostosis kind of picture. This is the CT scan 3D reconstruction. There is still opening of this thing, but predominantly it is looking like a dolichocephalic head, long head with pan-sutural synostosis. So at this age, the you can see the predominantly the posterior part of the skull has a lot of features of raised intracranial pressure because of the earlier on the lambdoid and sagittal sutures had closed. So what will be the option for this kid? So already it is a dolichocephalic head. So posterior cranial vault, directly going for a posterior cranial vault distraction may not be an ideal option. You may just to reduce the intracranial pressure, if you go for posterior cranial vault distraction, maybe you may make it more dolichocephalic. The other option that we had chosen is directly go for a and this is the fundus picture. So we went for a total cranial vault remodeling. Other than so I see this as an extension of scaphocephaly. Usually for scaphocephaly we go for a pie craniectomy and procedure similar to a pie craniectomy. You go and do a little bit more extensive remodeling called the Melbourne technique, modified Melbourne technique, where you take a small band of board behind the which involves both the frontal as well as anterior as well as the posterior. Basically, you have to reposition the vertex, reconstruct a new vertex at the move the vertex which is more posterior here and move the vertex and bring it higher up here. So this is what exactly was done in this case. You can see first the anterior procedure was done, and this is the posterior, where you can see the posterior sinus as well as the transverse sinus and torcula. And this was the pre-op, and this was the post-op, where you can see the skull becoming a little bit more rounder, and the dolichocephaly has shortened. And this is the kid at 6 months post-op with a more normal looking head, and this is the child at home being active and being a very fussy boss. Yeah, and this is at 5 years of age. So you can see from 3 to 5 years we have got to a stage where there is a more rounded, nice rounded head. Of course, there is some midface issues still persisting, but the development wise, the child is normal. There is no more headache. I mean, there are no more features of raised intracranial pressure. So this is one situation where I found total cranial vault remodeling very helpful. And this was the first case that I had done in AIIMS Bhubaneswar, and we have a follow-up. And as soon as I have done this procedure, I had texted both Dhaval sir and Suhas sir to discuss regarding this. Second stage is you can use it as a staged procedure. Like for example, you like this kid presented at 8 months of age, progressive increase in head size, abnormal head shape. There is significant OSA component, inability to hold the neck, difficulty to sit with without any support. And this was the presentation. You can see the child is obviously in distress. This is more of a brachycephaly kind of picture with a widely open frontal. I'll just go. I'll show you the the 3-dimensional picture. So that's the CT scan. You can see that there is wide open anterior fontanelle, and it's a more brachycephalic kind of a picture with again the same. So the Mercedes-Benz, the bilateral lambdoid and superior and sagittal suture synostosis BLSS variant. There are two different variants. One is the first variant that we saw, which is a longer head variant, dolichocephalic variant, where you can do the remodeling using a modified Melbourne technique. And this is a brachycephalic variant, where this is again there is a sagittal synostosis and bilateral lambdoid synostosis, Mercedes-Benz, but it is a brachycephalic variant. As well as you can see the posterior fossa is beaked in and indenting, causing crowding of the posterior fossa. So so this was the presentation, and the child also had significant hydrocephalus. So and with the crowding of the posterior fossa. Our initial plan was because it is a brachycephalic variant, OSA, hydrocephalus. The initial plan was to increase the cranial volume. So we first managed the hydrocephalus with an endoscopic ventriculostomy, and then went for a posterior cranial wall distraction. So this kid underwent posterior cranial wall distraction at 9 months of age. So the very interesting thing is that there are many times the endoscopic ventriculostomy is not very straightforward outcome in case of craniosynostosis, because along with the hydrocephalus there is foraminal stenosis, basal venous sinus stenosis. So absorption of CSF may not be that great. But in this kid, interestingly, as soon as the first day of ETV, post first day of ETV, the child started having a very good neck holding. Immediately, the child was able to lift her head up in the bed. So that gave us a good confidence. And then we went ahead and did a posterior cranial wall distraction for this child. So this was how the distractor Suhas sir had explained. We had gone infratorcular and did a posterior cranial wall distraction. This is the child being more comfortable and happy. And this is at the end of distraction, we had got this X-ray around 2 centimeter distraction we had done for this child. And this is the pre and post picture for comparison to see how much increase in cranial volume. Basically the skull has become a little bit more longer and has given extra space. So once this was done, we addressed the front part. So if you see the whole skull, you can see this. This is the posterior part. The one behind is the. So this is the anterior part, and this is the posterior part. But you see from the top, this looks like anterior, and this looks like posterior. So we did a complete remodeling of this skull shape. We just removed the anterior and posterior part and swapped basically. So that is what we had done in this kit. So this is one way of doing a staged total cranial wall remodeling. We are still the kit is this was recently done, and we are waiting for the edema and everything to settle down. But you can just see the whole change in shape of the skull pre and post operatively. So this is one way of going for a total cranial wall. Either you can go as a single stage, as well as you can go on multiple stages. Bilateral coronal synostosis, distraction osteogenesis is a good option. And as sir mentioned, there is a very important way where how you place the distractor vectors. So it has to be downward directed vectors for proper distraction. Or else when you go for a remodeling, you kind of swap the posterior part of the skull to the anterior part, so to get a proper proper frontal alignment. So this is how it is done. This is a case with upwards. So why I am showing this is I see this patient as a patient with bilateral coronal synostosis, or although the patient has pansutural synostosis, the morphology, I take it as the bilateral coronal synostosis, and we use the exact same plan for the this kid. So this is how the brachycephalic head with pansutural synostosis, predominantly bilateral coronal, with involvement of this thing skull base also. We did a swap. The whole procedure was done with similar how we do coronal synostosis, where both the sides of frontal bone as well as the frontoorbital band was taken and swapped from right to left. And the whole anterior fontanelle was reconstructed and taken behind, and the front part of the fontanelle was bridged using a small triangular piece of bone, and the rest of the bone was taken up and fixed. So this is how the pre and post-op picture looks like, more rounded. And the metopic synostosis is I'm showing this as a metopic synostosis. This is not a metopic synostosis. This is oxycephaly, but we see it as a kind of a metopic synostosis. So to decide regarding the planning. So this is the kid with pansutural synostosis, where we kind of in metopic synostosis you go for swapping of the posterior bone and bring it anteriorly. So we did a total cranial wall remodeling where the posterior part was taken, brought in front, and then the anterior part was taken back. This is the comparison after the 6 months post-op. You can see the nice frontal. This kid also has midface problem, but you can see the nice frontal curvature and reduction of this oxycephaly, more rounded head. We are still awaiting for the child to grow up to go for the midface procedure at a later stage. One interesting thing I have read, and then even Suhas sir mentioned, is about using asymmetrical distraction. Sir was mentioning it about asymmetrical distraction for posterior lambdoid synostosis. So this unilateral coronal synostosis is also one such situation where you can use this. Usually, this coronal synostosis, unilateral coronal synostosis, is coronal suture is basically where the two different areas of ossification, like basically the membranous ossification as well as enchondral ossification, and two different origin of skull bones meet, basically. So whenever there is a problem with the coronal suture, there is associated anomalies which involves the skull base also. So this is the typical Harlequin deformity that was explained by our previous speakers, Dr. Sabha and everyone. And it is told that Abraham Lincoln also has a little bit of unilateral coronal synostosis with flat one side head and a prominent ear on the side. So this is one of the patient where we had used this technique of the patient with unilateral coronal unicoronal synostosis, where we had used this technique of rotational destruction osteogenesis as so this is, I'll just run through the surgical video. Rotational destruction osteogenesis is used as a method of correcting this pathology. So usual bicoronal wavy lacy lazius incision was used, and as sir mentioned, we use colloidal tip monopolar for dissection. Use Rene clips with gauze, and you go sub above the periosteum and mark the incisions, mark the so if you can see here, along with the frontoorbital bando, we have marked the coronal unicoronal incision also goes around and goes and takes a hook like this. So this is the abnormal side and this is the normal side. If you can see the pointer, if my pointer is visible, so this is the normal side and this is the flatter side. So we use this point as an apex, and we used this as we used the craniotomy and taken this as the hinge. And along with the craniotome, I'll just I'll show you or sorry, 1 minute. I'm just trying to run the video. So this is how we separated the nerves along the supraorbital ridge. That's the marking for the orbital bando. And that is the whole marking for the craniotomy. We do the craniotomy that way and make sure there is a good mobilization. And once that is done, we go for orbital osteotomy using a chisel and mallet as well as reverse saw. And we make sure the bando as well as the bone is moving. We secure both this part using absorbable sutures, as well as we use so Surgiware has this mini plates and screws, so which are absorbable. So we use those this plate. So we use this plate, and then instead of putting a sonic pin, we put titanium pins. because the basically the plate will dissolve and the pins, the screws will remain. That way we can save some money. So because we wanted a more rigid construct between the frontal bone as well as the orbital bando, we use this construct. And along with that, once this is fixed, we used two distractors in the front on both the sides, one on top, one on bottom. And this is with distraction. And once the distraction is checked, the wound is the temporalis muscle is resutured and the wound is closed. This is the before starting distraction, and distraction is still continuing. You can see the frontal part is still, I mean, it is coming forward. We are just waiting for the whole thing to settle down for to see the final result. And this is one way of using asymmetrical distraction and total cranial vault remodeling for it. So this is another case which was initially first time operated outside somewhere, and then came back to us with significant proptosis as well as midface problem. Patient had severe OSA as well as orbital proptosis, multiple raised intracranial pressure features. So we did a frontoorbital total cranial vault as well as we did a midface distraction using a co-motor distractor. The details of which I think will be anyway, midface distraction will be discussed in detail later. So I will skip this part. This is the post-op the image for the kid. So the take-home message is early surgery, multidisciplinary approach, tailored management based on associated anomalies, management of blood loss, use of distraction osteogenesis in combination with the open procedures, use of ETB as opposed to shunt, and timing the midface, and keeping Chiari as important feature to keep in mind when we manage is all these will help us give a good overall outcome for the patients. So that's my last slide. Thank you.
Thank you. Thank you, Arun. Thank you very much. Actually, we are proud of Arun that he is carrying our legacy to other parts of the country. And that's what's the motto of our institute. Like, we should train people from all over the country so they can do good work throughout the country, and people need not to come to NIMHANS for treatment. So thank you, Arun, very much for covering the entire cranial vault procedure. Now we are going to less invasive procedure. So whole cranial vault remodeling is required for older children who have missed the bus, and the bones are no more soft, and we require complete cranial vault expansion with rigid fixation. But when the bones are still soft, baby is young, with less invasive procedure as well, we can do a great job. So for this, I invite Dr. Vaibhav. Dr. Vaibhav is a plastic surgeon, so who will be talking on suturectomy or synostectomy using endoscope, and then postoperative helmet molding therapy, which also gives equally good result. So like we heard about springs, and also earlier literature, if you go for a decade or two back, when it started, people initially actually started with just, if there is an abnormal suture, remove the abnormal suture and everything will be fine. But that never happened. Then it went into disfavor. Then springs came, then whole cranial vault procedure came. Now with refinement of techniques, good perioperative care available for small babies. Now again, minimally invasive procedures have come back, and with customized helmet therapy, now the minimally invasive procedures have become the first choice for single suture synostosis if babies come early. So I invite Dr. Vaibhav, who is working in Esther Whitefield Hospital in Bangalore, and he will be giving a talk on endoscopic synostectomy. Dr. Vaibhav, please.
First of all, thank you, Dr. Dhaval sir, and the whole department in NIMHANS for holding this conference and having such a great turnout. Usually we don't see that in craniosynostosis conferences, and it's really refreshing to note that. Now, personally, I have a disclosure that just this year we have started in-house helmet therapy services, orthotic helmet therapy services. We also support other neurosurgeons and plastic surgeons to set up their own in-house helmet therapy services. So that is an element of bias that you can factor in my talk. Starting off, why, as just Dhaval sir told, why coming to minimally invasive techniques at all? See, if we see the history of surgery, it's always been all surgeries becoming more and more minimally invasive. From open procedures, even in abdomen, you go to then laparoscopic, now robotic, so minimally invasive. But unfortunately, in craniosynostosis surgery, what we now regard as gold standard procedures are quite radical. And we started off with strip craniectomy, and we have progressed because strip craniectomy was not good enough. Then we progressed to further invasive techniques like frontoorbital advancement and total cranial wall remodeling, monoblock advancements, and things like that. So somewhere this was not sitting right in our psyche, and that's why we have kind of progressed to what best can be done with the minimally invasive techniques. And this is probably might have been a trigger to Professor David Jimenez as well, when he started off this technique way back in 1997 in Texas, US. So based on that, we offer endoscopic strip craniectomy and orthotic helmet therapy services in these indications, that is single suture craniosynostosis cases, with some exceptions. Like, for example, if we get a metopic and a unicoronal, it is still two sutures, but we still do that. But multi-suture, no, we don't do that. So single suture craniosynostosis with a few exceptions, and non-syndromic craniosynostosis without any exceptions. If we see that there is a syndrome involved, there is a significant gene involved, we are not going ahead with these techniques because we are still not confident that we'll be able to kind of avoid any raised intracranial pressure issues in these babies. So these two are our indications, and we call it as minimally invasive surgery and orthotic helmet therapy. Every word has a very definitive meaning. Although we probably tell it to our patients as endoscopic surgery, we might not use an endoscope at all during the surgery. If the main concept is being minimally invasive, that smaller scars, smaller surgery, lesser stay in the hospital, which will soothe the patients and the parents. And orthotic helmet therapy. Now, why orthotic helmet therapy is any helmet doesn't work. You will be approached by many companies who are biomedical engineers who will print a helmet for you. But the presence of an orthotist is extremely important. Orthotists are, if we don't know, are very certified paramedical people who have a 5-year course of BPO and then they do an MPO, and they are proper clinicians. And they are also allowed to use the term doctor as well. So the presence of that professional is absolutely crucial for the success of this treatment. So many people ask, what has changed? What is the difference between what suturectomy we did about 60 years back and the thing that we are doing right now? The difference is the addition of orthotic helmet therapy to get the outcome that we want. So although David Jimenez started in 1997, in India, these two gentlemen started, that is in Bangalore, Dr. Derek and Dr. Swarup Gopal, who is also an alumni of NIMHANS. And they started this in 2015. That was the first case when they did this technique of endoscopic surgery and helmet therapy. Initially, we used just printed helmets. That didn't work out very well. And then we had a very robust partner from the US, that is Ortho America, who started sending us the proper orthotic helmets, and we had orthotists doing the orthotic helmet therapy. Dr. Derek moved on to Dubai, and I was lucky enough to kind of team up with Dr. Swarup and continue the same team's work. Our numbers in the past 10 years, we have done about 79 cases of minimally invasive procedures. And the striking thing in these numbers is, see, since morning you've been hearing what is the most common craniosynostosis, and we have been hearing sagittal craniosynostosis. But somehow in our practice, we don't see that much of sagittal craniosynostosis. I am unable to kind of digest that fact that it is probably a genetic difference in Indians, but no, I feel it is either a lack of awareness in the population or a very cultural acceptance of sagittal craniosynostosis and scaphocephaly as a acceptable deformity, because it doesn't affect the face that much. Okay, he has a long head, so what? So that's why maybe people don't come for the treatment at all. So this has been our demography of patients who we have done the procedures on. And our protocol is pretty straightforward. It is any baby who comes to us before 6 months of age, we offer endoscopic assisted strip craniectomy. And as I told before, non-syndromic and single suture craniosynostosis. And anybody who comes after 6 months of age, we do the usual traditional gold standard techniques. So if somebody asks me, do you do open procedure or endoscopic procedure? I say we do both procedures, depending upon the age of the babies. We also wrote up our data as well. This was some of our earlier kind of data where, I mean, this is a no-brainer actually. It's a smaller surgery. So obviously the duration of surgery will be smaller. Obviously the blood loss will be very less. We have not transfused any baby till now in the 79 cases, except one baby who had a coagulation disorder. And ICU stay is not required at all. It started off as we used to keep the babies for 2 to 3 days, but now 24 hours post-surgery, we are discharging the babies. And the total stay also, as I mentioned, after 24 hours, we are discharging. This is a no-brainer because it's a smaller surgery. It is not comparable at all. What this helps is to kind of soothe the parents who are very concerned about a major procedure. And many times we call this procedure as a cosmetic procedure, which I also object to, because somebody born with a cleft lip, we wouldn't call that as a cosmetic procedure. That's a deformity. It's a congenital anomaly that we are correcting. So we have to use the terms that it is a congenital anomaly and it's a deformity correction surgery. It's not a cosmetic surgery. In addition to all the functional issues also that the babies might have with the raised intracranial pressure. So this is not a contention at all. It is a safer procedure. But the additional cost of a helmet therapy is always there. So if you actually kind of compare the costs of two procedures, the ultimate cost might be the same. There is definitely more effort from the parents in this procedure. We always counsel our parents, the parents, that you will have to do a lot of work. It is 50% surgery, 50% helmet therapy, and 50% extra from parents for the compliance of helmet therapy. All right. So that is extremely important. Now, I just wanted to show us this surgery's video. The surgery is very, very simple, right? I mean, I don't even have to show this video. As I told, it's the same strip craniectomy we have been doing, just in a little minimally invasive approach. We take care that the incision is always behind the hairline. We don't transgress the hairline, because after we shave the head, sometimes we forget where the hairline is. Make a small incision, give our local infiltration, maybe 2.5 to 3 centimeter incision, and then a subpalatal dissection. Then we just take a little bit of periosteum off, maybe a 2 centimeter strip from the fused suture. And depending upon which suture is involved, we use the endoscope once in a while to visualize and to make this video, but otherwise we don't need to use that endoscope. I'll be talking about this just a few minutes later. So we do a small burr hole. We always do this surgery together. We do open surgeries together, me and our neurosurgeon. So we do even this procedure together, although either him or me could do this alone, but still that's the main thing. One more thing that I want to impress upon, that when you're going out and starting out your own craniosynostosis practice, always team up. It's always better. The aesthetic aspects a maxillofacial surgeon or a plastic surgeon will be have a different perspective. And obviously the neurosurgical aspects, the neurosurgeon is the king, as we call brain is the king, right? So we try to keep the suture line as smooth as possible because we want to put a helmet on this baby after a week. So we don't want any stitches sticking out. So subcuticular closure with an absorbable suture would be the best possible approach. So that was the unicoronal part which you showed. There are other videos as well which you can see in the workshop. I'm just going to show what happens with metopic, that small incision that behind the hairline. We mark the suture from the anterior fontanelle to the frontonasal suture. It's extremely important to go all the way until the frontonasal suture, because or else we won't be correcting the hypotelorism at all of the metopic synostosis. In unicoronal, as I mentioned, hairline is very important. We need to put the cut just behind the hairline, somewhere midway in between the anterior fontanelle and the pterion. The original technique was just taking out the suture from the anterior fontanelle to pterion because that's where the coronal suture is. But what we found out with some studies is that as the baby grows older, that is 4 months, 5 months, 6 months, even the frontosphenoidal suture, which is the part of the coronal ring, they also start fusing. So that's why we take out even the frontosphenoidal suture also along with the coronal suture whenever we do the suturectomy. That makes scientific sense. We don't know how it is altering our outcomes, but it makes scientific sense. So that's why our suturectomy goes all the way from anterior fontanelle to all the way till all the free frontosphenoid sutures are also removed. Now, sometimes we wonder how will we go all the way until there. At the last part, our neurosurgeons puts a microscope on and we do some drilling over there. Either we use an ultrasonic scalpel or a piezo and just do some drilling at the last part where it's in the wing where the frontosphenoid suture is really thick. And this has been published as well. Sagittal suture, we usually use two incisions, one closer to the anterior fontanelle, one closer to the posterior fontanelle to take out, because it's a long suture, so we need more access. So two horizontal kind of transverse incisions to take out the whole suture. Once the surgery is done, as I told, 24 hours later, the baby goes home, and then we start the helmet therapy protocol as soon as possible. Now, this baby, this is not a helmet. This is the scanner that we use to prepare the helmet therapy. It's called a smart sock scanner. The scanner is done with an iPhone. That's a patented technology of the smart sock, which gives all the locations, and it gives a very beautiful reconstruction of the skull's shape, and those pointers are there. The scan takes about 5 minutes, and then we send that data to Ortho America, and they produce the helmet and send it back to us. Currently, we are having to go through the loops of importing it, customs, and all the Trump's tantrums. So, but things are going to be better for you all probably, because by the end of this year, they are going to have a manufacturing plant in India. So that's going to get easier, acquiring a good orthotic helmet. Now, helmet therapy, we usually start off as soon as possible, and we usually need 2 helmets for the whole treatment. The first helmet is for the first 3 to 4 months, and the next helmet is for the next 5 to 6 months. Because in the first 3 months, usually the growth is really rapid and the helmet fills out very fast. And then afterwards, the second helmet takes care of the residual deformities. And we usually stop the helmet therapy when we feel that we have attained the milestone, and then we still have some consolidation period and then wean the helmet off. So this weaning period can be 1 month or 2 months to kind of stabilize the final result. Most of the metopic synostosis babies require helmet therapy only until 12 months of age. Some of the unicoronal babies require treatment until 18 months of age. So the average is around 15 months of age. And the baby needs to see the orthotist every 3 weeks initially, and then every month or every month and a half later on. So this is also very important. Somebody living very remotely might not be a very good candidate for this technique. Somebody who is accessible, or you can be accessible to them, only then we can do this helmet therapy. So that is a conversation you need to have with your patients. Now that's the first helmet that we use on the left, that is called as a Star Light, because it's a hard silicone helmet, and you can see through, you can see the skin, you can see your incisions, so you can monitor if there are any wound issues and things like that very easily. And the second helmet after 3 to 4 months is what we call as the Star Band that we use. As you can see, there's a lot more foam in it, so there is a lot of room for adjustment, and babies are very comfortable, except the first 1 week. Babies tend to adjust to the helmets pretty well. So that's just a video of the Star Light helmet. As you can see, it's hard silicone and it's a side opening helmet. And this is a Star Band helmet, which has a lot of foam, as you can see, and that's why it lasts longer, 5 to 6 months. The orthotist can keep adjusting the helmet and shave the helmet off so that it fills out. The whole concept of helmet therapy is passive molding. We are not compressing the head. We are holding the head so that strategically we can direct the brain to do all the weight lifting. The brain does all the work in this technique, not the helmet. Helmet just holds the head, holds the head. The brain is pushing where the deformity needs to be corrected. That's why in the open technique, we see amazing results on table. And then when we see the baby maybe 6 or 7 years later, it has regressed a little bit, temporal hollowing comes in and things like that. Whereas in endoscopic technique, on the table, there is no change because we're just suturectomy, but results keep improving over a period of time. So outcomes, we have seen our outcomes as well. We have shown equivalence. We have only 10-year data, but I've even visited the team which started it all in 1997 in El Paso. So they have 29-year data, and they have shown in their papers that the outcomes are equivalent, same as an open surgery. So if your outcomes are equivalent, and if you can get away with a smaller surgery, I mean, it's a no debate regarding which technique, not you will choose, but which technique the parents will choose. So ultimately, parents are the decision makers. Not even once has any parent told me that, okay, sir, do me the open surgery when I give both the options. So every time they choose endoscopic surgery, and it is pretty straightforward. We have had 3 patients in our group whom we have offered redo surgery, but they haven't taken it up. Beta staging, as Dr. Dhaval told, it's a surgeon kind of an assessment. We feel that we have not done enough for that baby, but the parents are happy and they have not gone for any redo surgery. We have never done a redo surgery till now, touch wood. Some of the outcomes, as you can see, unicoronal babies, before and after pictures. And this is the scan that we do to monitor. And you can see how the forehead fills out at the strategic areas. And that's at age 3 years. See, one thing you can see in unicoronal craniosynostosis, we say the forehead will become symmetrical, but the eyebrow might still lag behind. At the end of the helmet therapy, the eyebrow doesn't correct. Only when this part of the face grows, that's when that will get corrected. All the secondary changes of craniosynostosis will only get corrected with growth. And that's what happens. The eyebrow gets corrected usually by around 3 to 4 years time. And you can see the outcome at 3 years. One more unicoronal case, one more case to that. These are all outcomes of unicoronal cases, and we do this monitoring, and there is an index called cranial wall tessimetry index that we can monitor, see how it has kind of only improved over a period of time. And then there is metopic synostosis, very similarly, very decent outcomes, no temporal hollowing. This is the end of 2 years. Helmet therapy is over. They've come back for a final review. And that's a very objective kind of a outcome that you can notice. I mean, you won't even know what the diagnosis was if we don't tell. So that's how that's the final goal. And obviously with a 2 to 3 centimeter scar. sagittal synostosis as well. See how the posterior occipital region has just filled out. And anteriorly also baby looks that biparietal shortening has just opened up completely anteriorly as well. And a reduction in the AP diameter. Issues, yeah, obviously, if you're doing enough cases, you will have issues. Compliance is the main thing. We need to keep motivating the parents to put it on. Even during summer, in Delhi also, parents wear it. Babies are very comfortable. Whenever there is a fever or something like that, we ask them to give a break and then put it back on. If there is a social event, the naming ceremony or whatever it is, they can take a break that day, no problem at all. Helmet has to be worn 23 hours in a day otherwise. And I mean, it's only about being culturally accepted that there are babies who need helmet therapy. Recently in the US Open, you might have seen one baby became famous with the helmet, all the stars signing the helmet of that cute baby. Skin pressure necrosis, if not monitored well, redness can lead to a little bit of an ulceration. That time again, we give a break and it usually heals off. Then there is a questionable lag in the head circumference also during the helmet therapy, but that lag becomes absolutely normal once the helmet therapy is stopped and then they come back. This is only my personal observation. There is no documented data regarding this. And then there is contact dermatitis. We had a really that one of the 3 babies had contact dermatitis. So we had to kind of change the type of the helmet that we used. We had to switch from the foam-based helmet to the silicone helmet and then baby. But we have offered redo surgery for this baby, redo open surgery, but the parents don't want it. And this is a baby who is now a 10-year-old. The first case he was done in 2015, the metopic synostosis. And we do follow all our single suture cases until 12 years of age. We are only 10 years old, but our intention is to keep the follow until at least 12 years of age. Thank you very much. That's our new team. And you can see 2 NIMANS alumni there, Dr. Swaroop and Dr. Dheeraj, who is our neuro anesthesia lead.
Thank you, Vaibhav. That was really wonderful. So you realize that there are more than one way to skin the cat. Like you can use very minimally invasive surgery with orthotics and that gives equally good result. So that's the difference between a plastic surgeon and neurosurgeon, right? They see it differently and they do it also differently. One question I'll ask to any of the residents: how many bones are there in human head? Anybody? Yeah, Tejaswini. So there are 22 bones, right? And only 8 are in cranium. Rest of the 14 bones are in face. So no surgery or no treatment for craniosynostosis is complete without addressing the face. Particularly in syndromic synostosis, face is the main part which is involved. And even in non-syndromic synostosis, like in metopic and unicoronal, there is retrusion of the orbit, which also needs to be taken care. And as neurosurgeons, we do not see below the orbit. But when it comes to craniosynostosis, we have to see entire face. When you ask for CT scan, also you have to ask for entire head CT scan, not just cranial CT scan. So for this, we have Dr. Krishna Sharma Rao, who is a maxillofacial surgeon. And he is very popular among children and among parents of the children. Like, he has given smiles to so many thousands and thousands of children, and smile is contagious. So if child smile, entire society smiles. So he has put on smiles of the entire society. And he runs a foundation called Inga Health Foundation, under which he has benefited thousands of children with low cost of free of charge surgeries, and he has done tremendous job in maxillofacial surgery. So we are really grateful to have Dr. Krishna Sharma Rao among us, who will be giving a talk on midface surgeries for craniosynostosis. So please.
Thank you. I think it's getting close to lunch for all of you, and you have had a wonderful morning today. And I hope you don't fall asleep or feel hungry till I finish. I'll be talking basically about midface distraction. In craniosynostosis, you already know all this. You have syndromic and non-syndromic. You can have single suture or multi-sutural synostosis, which also includes the skull base. Now, the skull base is very important because it determines the face and the growth of the midface. So if the skull base is fused for any reason or abnormal, you'll find that the midface also does not grow. So the technique of distraction osteogenesis already been explained by many stalwarts before me who spoke about posterior calvarial distraction. The technique is same, basically. It's stretching the bone, lengthening the bone, approximately 1 millimeter a day to the desired distance. And as the growth is very slow, it also stretches the soft tissues, which includes the nerves, the blood vessels, skin, everything else. And these devices which we use can be internal or external. For example, this is a red device, and this can be used as an external device to distract the midface. You also get intraoral devices for maxillary advancement. The disadvantage of this is that they cannot distract a lot, unlike RED or other types of REDs, which can distract more than 2 centimeters. And also you can change direction if you want. You cannot do that with a intraoral device. The common uses of distraction related to craniosynostosis largely is in syndromic cases, whether it's Grudon, Apert, Pfeiffer, or many others like the geneticist before me spoke about. There are multiple names, multiple genes, but the technique is more or less the same. So the indication is mainly obstructive sleep apnea. Today, obstructive sleep apnea causes a lot of problems. And we have seen the end result of this in children who have not undergone the procedure and ended up passing away at home due to lack of the procedure. And they never reach adulthood. This is the reason you don't see so many patients with severe syndromes reach adulthood. Mild Cruzons, you can see familial, you can see them growing as adults, but once they get some complication, you don't see them actually past adolescence. Of course, exorbitism with corneal exposure is an indication, obviously, and class 3 malocclusion for an older child is aesthetic and functional indication. The main procedure is a Lefort 3 osteotomy. So basically, you move the entire skeletal of the midface, including the nasal bones, including the floor of the orbit, including the zygoma and the maxilla at the same time and bring it forward. You can also combine it with a simultaneous Lefort 1 osteotomy. So in decision making, this is the debate I have very often. You can have a child with multisutural synostosis with or without raised ICP, Carey malformation with or without syrinx, exorbitism, respiratory distress, secondary to OSA, failure to thrive. Now, as per traditional technique, we would address the skull first, and we would have probably done a posterior calvarial wall distraction with or without a shunt if there is a Carey malformation and a syrinx. You can do frontoorbital advancement with cranial wall remodeling. You can do a Lefort 3 distraction osteotomy. However, if the respiratory distress overwhelms the clinical situation, wherein you actually have to treat that first, you can go the other way around and do the midface advancement first and then do the cranial wall remodeling. So midface distraction is a staging procedure. It's not a final procedure. It's not the procedure, it's a procedure to save the life of the child, to prevent damage to the eye and the globe, and then eventually, when they are older, to do a finishing procedure, which is a traditional osteotomy. So the biology of distraction, you are already aware of. It's been spoken again in the morning. And unlike a standard osteotomy, where the soft tissues are the limiting factor, here in distraction, it is not. So there are many aspects to distraction. And basically, as initially explained by Elizarov, for long bones, which was adapted. And I think I started doing distraction in 1993 and craniosynostosis in 94. So distraction preceded my venturing into cranial surgery. So the technique is always the same. It's a formal osteotomy of the bone, whichever bone that you are osteotomizing. And then you move it slowly after the initial waiting period so that the callus can be lengthened. So it depends on, in cleft patients also, it's another technique that you can use to correct the midface hypoplasia. So I'll show a few cleft cases as well, apart from syndromic cases of craniosynostosis. Timing, you can do it at any stage, depending on the condition of the child. I've had children with Treacher-Collins, not craniosynostosis, Treacher-Collins or Pierre-Robin sequence with severe respiratory distress. And on the day of birth, we had to do a tracheostomy, followed by distraction, and then remove the distractor about a month later. And the child is able to thrive well. I will not be showing that because it's not in today's topic of discussion, but it's very important. So this is the comparison between distraction or traditional osteotomies. Distraction has significant advantages. And the problems are, of course, compliance with the device or a device failure. These are the most important complications. The rest, in terms of infection, damage to vital structure, is very minimal. So let me show you some patients and explain how the distraction was done. So here's children with severe midface hypoplasia, Binder syndrome, hemifacial microsomia, craniofacial microsomia. So treatment planning is clinical evaluation, 3D modeling, X-rays, cephalometric analysis, and 3D simulation. Here's a cleft patient with severe midface hypoplasia. So these are the old techniques where we used to take dental cast. This was done about 20 years ago. Today we can take laser images of the teeth and get occlusion in proper 3D format. So let me go to the patient so you have an idea about how the distraction works. Planned osteotomy, fixation of device, and the protocol, latency, distraction of 1 millimeter, and you remove the distraction with or with the rigid fixation. So there are many other things like vectors and other things that you need to consider, and the cost of the distractor. Today you get Indian distractors, which are 1/10 the cost of the imported ones like ALS Martin, and you can easily convince your patients to afford to buy these. So these are maxillary Molina type of distractors. There are RED distractors. So here's a distractor in C2. Another distractor in C2. So it is fixed to the maxilla in the pyriform rim with a plate. This is a mandibular distractor in situ for a Lefort 1 osteotomy. And let me just get to the syndromic children. So here's a Crouzons with severe midface hypoplasia, exorbitism, flat forehead. This is the skeletal structure. Underwent frontoorbital advancement with cranial vault remodeling as a stage 1 procedure. Everything was repositioned. Advancement was done. This is post-advancement. Forehead advanced by more than 2 centimeters. Still has exorbitism in the inferior region with obstructive sleep apnea. Underwent a RED to distract the midface. And this is her today post-distraction, post-Lefort 3 osteotomy, undergoing orthodontics and settling down. So from here to here, which is both frontoorbital remodeling as well as midface advancement. So it's a 18-year journey. You start with the child being 6 months to a year old when you do the cranial vault remodeling, and you can distract much earlier, maybe at the age of 7, 8, 9, and you may have to do a finishing procedure of orthognathic surgery when the child is about 17 or 18. Another child with Cruzon and acanthosis nigricans together, which is quite common, and underwent cranial vault remodeling and distraction, osteogenesis. This is him after a decade, actually. The midface is forward. He's growing well. He's in school, college now. So this is the child before, and this is the child today. Another child with Cruzons, severe midface hypoplasia, cranial vault remodeling, post-surgery, then underwent distraction of the midface. And this is him today, post-distraction. So he's now about 14 or 15 years old, and he's had his cranial vault remodeling. He has had his Lefort 3 distraction as well. Before and after. He still need orthodontics and routine settling of his dentition. Is a child who presented to us having been operated earlier with severe loss of bone, basically islands of bone, had a mesh in his frontal bone area. And though he was having OSA and needed an RED, we had to modify the technique a bit because there was not enough purchase in the bone itself because of the loss of bone. So he underwent RED by putting an old technique, something we used to do in the 1960s, where like you would treat a fracture with a POP cast, we would put a POP cast around the skull. So the POP became the skull for the child. And that's where the distractor was positioned. So the pins of the distractor were actually inside the plaster of Paris and not on the skull, because he couldn't do it on the skull. And then the midface was distracted. All the osteotomies can be done through the same incision, which is the bicoronal incision. Here's another child with a significant Cruzon, operated earlier, had a resurgery, and then underwent distraction of the midface. And this is him today, going to school. He's growing well. So these are other traditional techniques for cleft patients, a Lefort 3 distraction. You can also do a Lefort 1 distraction in these patients, a high Lefort 1. This is another technique where you do a maxillary only distraction, high Lefort 1 distraction, high Lefort 1 distraction, a Lefort 3 distraction, and a face mask to hold the distraction in place. So basically, the RED is a very, very flexible device. He has an internal device with the rod protruding outside. Underwent a unilateral Lefort 3 osteotomy and that distraction of one side of the face only. So another Lefort distraction. So basically, if you see that relapse is very low, growth is good, all of them require some procedure at the age of 18 years to do the finishing of their dental occlusion and their aesthetics. And the presence of a pharyngeal flap or anything else, as in a cleft, would not affect the distraction process, unlike a standard surgery. Complications, infection, bone necrosis, tooth loss, all very rare. Today, we have very good quality instrumentation, even made in India, so we could avoid most of the complications. So these are some intraoral maxillary advancements using intraoral distractors. Again, using an intraoral distractor and a forehead flap to do the nose. Intraoral distraction. So advantages of RED versus DO. In terms of vector control, RED is better. In terms of distance to go, external device is better. You can also do simultaneous maxillomandibular distraction in cases where the face is asymmetric. Like in a hemifacial microsomia, you can also do it in severe cases of coronal synostosis with harlequin deformity, who also present with facial asymmetry over a period of time. So you can distract, do a Lefort 1 osteotomy, distract the mandible, do intermaxillary fixation, and move both together to achieve facial symmetry with a single device. So this is simultaneous maxillomandibular distraction. Potential complications we have already discussed. In these cases, it's again minimal persistent occlusal cant and need for maybe a corrective procedure like a genioplasty or fat graft as a finishing procedure. Conclusion, there's a role of distraction in correcting skeletal deformities, post craniosynostosis correction, post cleft lip and palate correction, and post other syndromic correction. You can do large advances with minimal relapse, and you can simultaneously adapt the soft tissue envelope. Speech is preserved, minimizes secondary deformity. We don't tend to overcorrect, we correct as much as is necessary. We know that the midface will not grow even in a child with Cruzon or Epert's, or a child with cleft lip and palate. The midface doesn't grow very well, and they will need a second procedure at the end of it. Thank you.
Thank you very much, sir. So all of you agree that sir's talk brought smiles on our face, even if we are hungry. So we have one more talk on midface procedures by Dr. Girish Rao, who is currently not available because I understand there is one maxillofacial con going on in Kerala, and quite a few maxillofacial surgeons are over there. So he could not make it in person. So he has sent recorded talk. So immediately after this talk, we'll go for lunch. So please have some more patience. And then after this talk, we'll break for lunch. We thanks Dr. Girish Rao wherever he's listening to us. So we have Dr. Girish Rao student. Please pass on our gratitude to him. And this brings to the end of our pre-lunch session, that is talk. So we will have just a couple of minutes felicitation session for our faculties. Then we'll break for lunch, and then we will go to our skills lab. So I request Dr. Subhash to deliver vote of thanks.
Thank you all for coming, and we are in the mid-phase of our CME. So before going for a lunch, a small program to felicitate our faculty. So I'll invite Professor Dhaval Shukla sir and Professor Dwarkanath sir to felicitate Dr. Suhash. Sir, can you come to stage? Thank you, sir, for coming with short notice, giving a nice talk, sir. Thank you. Now I'll invite Dr. Vaibhav to come to the stage. Vaibhav has given a nice talk, minimally invasive. So with this, we end this program. I thank to the administrator for giving permission for this function. And thanks to our sponsor, KLS Martin and Dr. Reddy for sponsoring this program. Thanks to our resident for without their support, we cannot complete any function in our department. And thanks to our research fellows, especially Tejaswini is actively involved. She has made a lot of contribution. Thank you all. And one more thing, for the certificate, there is a QR code. You have to scan the QR code. Automatically, will receive receive in email the certificate. So after this, you enjoy your lunch and then come to cadaver lab. So where we'll have a fourth station where we'll discuss about the surgical steps. Experts will be available. You can ask your doubt and you can practice if the model is available. Thank you. Thank you.
And